we'll get started. So financial disclosures, which I just, well, I can take this off. I'm not on the sleep medicine exam committee. Right, she's actually up to date. So what we're going to talk about is just, we're going to focus on adults, obstructive sleep apnea. And we'll talk about kind of what it is, because that's actually a big problem in sleep medicine, as you guys will find out if you haven't already heard. There's some controversial areas and some things in flux. Then we'll talk about epidemiology, risk factors. A lot of stuff seems kind of obvious, but you'll hopefully get some nuanced things here. And then talk about consequences, diagnostic strategies, and treatment options, of which there's an ever-growing array of things to do, and trying to put those in context for our patients. This is designed, again, to give somewhat, well, we'll go over some data, but a lot of it's going to be kind of a bird's eye view of things. Like I said, a lot of these things can go into much more depth, and you'll be hearing a lot more about some of these topics over the course of the year. So there's that. So one of the issues is, how do we define sleep apnea? So you guys know about the ICSD, right? National Classification Sleep Disorders. You guys all members of ASM. You guys all get did you get an ICSD yet? Yeah, yes. Yeah. Okay. Yeah. So you're gonna want to spend time reading that this year. A lot of test questions for your test exam will come out of that. They have to get to go. But it is how we it's sort of the diagnosis and prevalence, risk factors, differential diagnosis, all that information is in each disorder. And they did a text revision in 2023 that came out, which they actually changed how we define obstructive sleep apnea in some regards. So this is a traditional definition. I'll show you what the change is here. So you need to either have A and B or just C, and we'll show you what C is in a minute. So A is some sort of symptoms and or the comorbid conditions. So by symptoms, we'll talk about these in some more detail: sleepiness, fatigue, insomnia. So the things you guys will find out is that not everybody complains of sleepiness. And actually, it's only like 40–50% of adults will complain of subjective sleepiness. So you have it's coming in that have low Epworths or normal Epworths. So, and it's different by culture, by gender, by age, all those things can influence it. So a lot of people complain more, like women tend to complain more fatigue than sleepiness. Insomnia can be a lead factor. Gasping, choking at night, witness to apneas, loud snoring. So if they can have any of these things, and then traditionally it had been the diagnosis of hypertension, mood disorder, cognitive function, coronary disease, stroke, just heart failure, diabetes, and we'll talk about why those things were in the original definition. So you could have any of those things, and then some objective test to prove that the sleep apnea is present, and this could either be a PSG or a home sleep apnea test. We'll talk about those in a little while. And you just have to have 5 or more events per hour. We'll talk about what we mean by events. So the big change with the, so I guess we'll do that in the red here. So you need to have A and B symptoms and an HI, or some labs will score RERAs, and we'll talk about what those are. And that's an area of controversy. But we kind of use it as a way to get around some of the problems with CMS. So symptoms are the HI or RDI more than 5, or if you just have more than 15. So it doesn't matter if you're totally asymptomatic and you don't have any other comorbid problems. If your breathing index is more than 15 events per hour, that's enough to get you qualified as having OSA and get you on treatment. So what the ICSD text revision does, they actually took out those comorbid conditions. So now the diagnosis no longer, you can't just have hypertension, HI more than 5. You have to have symptoms and a breathing index more than 5 in order to qualify as OSA, or 15 regardless of symptoms. So this is one of the big areas of controversy, is how we define the respiratory events. So unfortunately, a number of years ago, there was sort of this break where CMS kind of looked at the data and said, looks like most cardiovascular outcomes are coming from hypoxia, talk about hypoxic burden. And so they actually said, we want to see big reductions in oxygenation in order to qualify as a respiratory event. So in apnea, everybody agrees on. Apnea is stop breathing for 10 seconds. Doesn't matter if you have DSAT or arousal, doesn't matter. You just stop breathing for 10 seconds, the ongoing effort, that's an apnea, obstructive The hypopnea is where the problem is. So this is a reduction. So everyone says, okay, 30% reduction, which is subjective. Nobody's actually scaling this usually exactly. But it's kind of a subjective measure. But what CMS said was 4% or more, that these events have to be for 10 seconds. Then they have to have 4% DSAT. That's actually pretty marked DSAT. And we'll see how that impacts things clinically here in a minute. Whereas the American Academy of Sleep Medicine said, you know, it can't just be 3%, it doesn't have to be 4%, and or an arousal. So you don't have to DSAT at all. You can just, if you just wake up from it, people aren't fully aware they're waking up. It's a EED arousal we're seeing. And initially, when the scoring, you guys go on the AMS website and you look at this, you know, the scoring manual, there's tons of versions now. There's probably like 15 versions of it now. So when it came out, they actually used CMS as a recommended one. And that was because of the data. But since then, more data has come out showing that, you know, less of a DSAT is important. Arousals are important, you know, because you get sympathetic surge and, you know, that can happen during that time. So a lot of the same outcomes can occur. And then in addition, patients can not meet that 4% DSAT criteria, but they can be very, very symptomatic with just 3% or arousals. You know, people that are profoundly sleepy and they won't qualify because they don't DSAT straight enough by CMS. So this is it's a big schism here because, and so that it's been an ongoing controversy and they keep talking about it and go back to CMS, asking to reinvestigate this, but they keep backing off because if CMS says, okay, we'll look at this thing, look at everything in sleep medicine, they all those issues with PAP therapy and blah, blah, blah. So there's been a workshop and Dr. Krishnan, you guys will meet, she's out of the country right now, but she was on the hypopnea workshop. And I think they kind of concluded that they need some more research. But it creates a huge difference. So as you'll see, there are some patients where their CMS AHI will be like 3 or 2 or 1 or 0 because they don't desaturate. But they can have an AHI of 40 or 60 if you go by ASM. So it looks like it's really severe by ASM, but not by CMS. And that becomes a problem because if you just go strictly by the CMS scoring, which some labs, as you network and go around and look at jobs and stuff, you can find some labs only score by CMS, some will score by both. We score by both. But we have a workaround with that, which we'll talk about in a second. Because otherwise you got all these people that are coming in, got bad sleep apnea and you can't get them treatment if they have Medicare or Medicaid. Some private insurance, probably CMS guidance. So it's a huge problem, and it's a huge problem when you look at the literature. Because when you look at the literature, people can say AHI, we use AHI, blah, blah, 5, 10, 15, or whatever to define sleep apnea. You got to know how they scored it specifically. Because sometimes you're comparing apples and oranges. So the number of apneas and hypopneas per hour is the AHI, and it's per hour of sleep. Actually, need to fix that. So it's per hour of sleep on a PSG. And we consider normal to be up to 5. So we actually, most of us do this a little bit. You'll see a lot of transitional hypopneas when people are falling from awake to sleep. And so it's not uncommon to see a little bit of some mild breathing disturbance. But the data really supports, and this was actually defined kind of arbitrarily initially, and the data is kind of coming afterwards, but it does suggest that probably significant consequences occurred more than 5. So less than 5, you don't have sleep apnea. This is in the recognition that things can vary night to night. So if you have a really high clinical suspicion, in some cases, it might be reasonable to repeat a study on someone. So for instance, they didn't have enough REM sleep or supine sleep and sleep apnea can be worse. You may want to repeat it because there is some probably night to night variability, 20% of the time people will switch categories. 5 to 15 is considered mild, 15 to 30 is moderate, more than 30 is severe. Probably the biggest cutoff here really is the 15 because that's where a lot of the data comes for the cardiovascular outcomes. And then for a while there was this term, and you'll see in the literature, sleep apnea hypopnea syndrome. Most people just say OSA now, but that was more than 5 with symptoms. And actually it needs to be fixed there also because we can't have the comorbid conditions in. So now there's also this, so we talked about apnea. So this is this was my talk, and then I added about 30 slides. ASM has a talk on OSA basics, so I was reviewing that and added some of their slides. And so this is one of their slides. So in this, they include the definition. So we talked about apnea, we talked about hypopnea, 30%, 10 second, 3% or an arousal. There's also this respiratory effort related arousal, which is an area of controversy as well. There's some big believers in this. One of the big, grandfather of sleep medicine, Christian Guilleminault, who's passed away a few years back. He was really big on this and would score this all the time. So what these are where there's a reduction in airflow but does meet that 30%, or they don't desat with it, but they arouse with it. So they can have a 20% reduction in airflow and then have an arousal. So it's a respiratory effort related arousal. It's not a hypopnea. So again, doesn't meet that criteria. So this is kind of our workaround in Metro. What we do when we score our studies, if their CMS AHI is low, but their ASM AHI is high. So there's a loophole in the CMS where it actually allows for the respiratory effort related arousals to be scored. So we'll go back, rescore those in those studies. And then we report a CMS RDI, which is a respiratory disturbance index. So the apnea-hypopnea index, and there's a respiratory disturbance index. We include the AHI in our report, but we the summary just has the RDI and we've been able to get patients therapy through that route. But you see some centers where a lot of centers don't do that. They'll just report the CMS thing, and then you have a lot of patients that they can't get treatment for it. And trust me, it's very angry patients who can't get treated, and very symptomatic patients. So graphically, what this looks like, so we won't go into a whole lot of detail, but the PSG montage, but the airflow, the effort, the O2 sat, so breathing, effort to breathe. There's no flow. And this is defined on the pressure, or I'm sorry, the thermistor for an apnea. And usually you'll see a reduction in the effort during that time, which gets the whole kind of pathophysiology. We'll come back to that. And then typically there's a desaturation that comes, and the desaturation pattern often looks like this. It sort of tends to do a slow desat and then a rapid resaturation as they have their hyperpnea to fix when they open their airway back up again. The reason that's important is sometimes people talk about the central sleep apneas, which we're not going to talk about today, but they have more of a symmetrical desat resat pattern. Although when they try to do studies to say, just looking at oximetry, can you differentiate between the two? They explicitly shown. But that's sort of the classic. This is different from a central apnea in which they have no flow, but there's also no effort to breathe. It tends to have this more symmetrical. So central apneas can occur in this context of obstructive apneas, and often we do have these as we fall asleep. That's a whole nother topic to go into right now. And then hypopneas are where we have this reduction in airflow, but there's still ongoing airflow. You may or may not see a desaturation. It could be completely flat saturation curve, or there may be a mild desat with it. So again, this is ASM, so apnea, which has to be defined on the thermistor. So we actually define, so there's a pressure cannula and a thermistor. So pressure measures pressure changes and thermistor measures temperature changes. Turns out the pressure cannula is more sensitive for hypopneas, and the thermistor is more sensitive for apneas. So that's what they're supposed to be scored up. So here, so PSGs typically have both of these, and you're going to see no flow for at least 10 seconds, and then desat. Hypopnea again, just so we looked at, so no flow. And you can notice a reduction in effort with both of these. And then ARERA, so this is where there's a reduction in airflow, and they don't have the brainwave tracing here, but what you'd see would be a brief arousal in the brainwave tracing. So the patient's sleep is interrupted or fragmented, but they don't have any accompanying desaturation. So just keep things a little bit interesting. A little celebrity sleep apnea. So you guys know this is. I can't. Very good. You can do better than a lot of health staff. John Candy. So John Candy died of sleep at age 43. Of course, he was very overweight, but he had sleep apnea as well. Died of an MI in his sleep. So you correlate with some of this stuff that this week. All right, so when you look at older literature, so the prevalence, how common is sleep apnea? So this was the mantra for a long time. If you did any of the older studies, they'd always start off, everybody says sleep apnea is common in society, 2% of men, or 2% of women, 4% of men. And this was the Wisconsin sleep cohort. So have you guys heard anything about this cohort? So this is actually so there's a couple of really big studies which generated hundreds of papers now because they collected all this data. This is one of them. This is a study that was very smartly done in that they did not use a clinic for this. They actually recruited workers from the state government workers from Wisconsin to be in the study. So they didn't go to any clinics or healthcare system or anything like that. And what they agreed to do was to get sleep studies done. So they got PSGs done, filled out a whole bunch of questionnaires, physical exams, blood work, all this sort of stuff. And then they started watching these patients, see what happened. So every 4 years since then, they've been repeating their sleep studies up until, I think it's probably stopped now, but their latest data, which we'll show you in a second, is now 10 years old. So this was the first cohort. So they had about almost 3,000 individuals in the study, and they reported that these were the findings they had. So this was what the mantra was. They then updated it in 2011. So it actually was published in 2013. So, not everybody's still involved in the study. Some dropped off, some moved, some have passed away. And I'll show you some more details on this, but it changed dramatically from that 4% now to 15% in men, 2% to 4% in women. So this is kind of this, or 5%, sorry. So this is kind of the standard by which we talk about in terms of prevalence. And then specific population. So again, this is a community dwelling population. This is not a population that's coming into your medicine clinic or peds clinic or family practice clinic. It's all adults and not peds. But if you start throwing in comorbidities, the prevalence rates go up quite a bit. I'll talk about that. So a couple things to note with this updated Wisconsin sleep cohort prevalence study. So one, they used that AHI 4% of more than 15. So this is a very conservative definition of what sleep apnea is, right? So it's not 5, and it's not the ASM definition. This is 4% DSATs, and you gotta have at least moderate disease. So this is pretty significant disease. So given that, it's still 15% of men. I'm sorry, 14% of men and 5% of women. And then they broke it out also by age. So by gender, by age, and then by BMI. So clearly, as we know, as you get older, unfortunately, your tissues become more floppy, and crowd the airway easier, so sleep apnea is more prevalent. But also as you gain weight, right, the upper airway narrows, fatty tissue unfortunately deposits around the airway, that crowds it and narrows it up. So these are BMIs here. So once you get to the obese category in men, so this is kind of 30 to 50-year-old men, it actually goes up a little bit, 17%, but if your BMI is more than 40%, over half of them will have OSA. So BMI is a huge predictor as age, and that gets worse, a little bit worse as you get older, so that particularly in the less obese patients, so here in the 25, the overweight but not obese, 4% to 11%, and then the obese, 16 to 29, so roughly doubles. When you get to morbidly obese, doesn't matter. Similar sort of findings in women. There's a sort of dose-response relationship the older you get, but particularly postmenopausal women, so they lose some of the hormones, and that their prevalence rates will start to decline after menopause. And as they gain weight as well. So if you look at a younger woman who's got a BMI over 40, it's up to almost 20% have OSA, and then about a third if they're over the age of 50. So again, this is very conservative estimates because it's using 4% criteria and with AHI more than 15. So the hypopnea definition, we talked about that 3% versus 4% really does have a big influence. So this is a meta-analysis, 6,000 patients. I can't remember this how exactly to interpret this graph. But it ends up ending up, I think it's because it's around 20% here, 20% or 80% there. So 20% additional diagnosis with the 3%. So you're missing 20% is a pretty big number. You're missing a lot of people if you just go by that 4% criteria. And then we did a study. So there's some data supporting this. Other things along the hypopnea issue, younger patients less likely to be eligible for treatment. And then we did a study here. We just went back and looked because we score both, because I thought there's this gender bias. So as you'll see, women tend to have more hypopnea-based sleep apnea. Don't have. So if you take a woman and a man, same age, same BMI, man's much more likely to have OSA, more severe OSA. They're more likely to have apneas as opposed to hypopneas. Women are more likely to have low arousal threshold where they wake up and they don't desaturate as much. So we went back and just looked at a bunch of diagnostic studies in our lab, and we matched, men and women, matched on a bunch of parameters, including their age and BMI, and found that women were almost twofold less likely to be eligible for treatment. And we probably should have broke it out in this age group of 50, over 50, for the postmenopausal, but we didn't. We had under 40, 40, 60, and over 60, so that's clearly postmenopausal. And then by the BMIs, so if you're a woman in the age 40 to 60 and your BMI is over 40, your odds of qualifying for treatment actually are almost sevenfold less than a man in those same findings. So there's actually a gender bias built into this as well. So Faiza was a lead author. You guys will meet her, Faiza Khalid. So this is something she started during her sleep fellowship, finished up afterwards. Took a bit more work than we thought, but this will highlight something that could potentially be done during fellowship. But so there's a problem with this definition. And again, these are all people who have AHIs around 60, depending on how you're defining if you use ASM criteria. So you have someone here who's really having arousal-based hypopnea or arousal and hypopnea-based sleep apnea. They don't desaturate very much. Here's someone that doesn't desaturate too much, probably until they go into probably REM sleep, and then they have some desats and it's kind of mild. They're not dropping below 90 that much. But here's someone who's clearly probably just having apnea. They're spending a lot of time with the low oxygen level. The CPAP gets started here. But if you just look at their strict AHI, so you're going to hear over the course of the year, there's a lot of calls and it's been going on for a while that we need a better metric to determine not just definition of sleep apnea, but sleep apnea severity, and then how it relates clinically to patients. So the AHI doesn't correlate very well with sleepiness. There's data, some with the cardiovascular outcomes, but actually the data is better based on the big thing you'll hear about these days, hypoxic burdens, how much time. And the problem there is we don't have a uniform definition of what hypoxic burden is. So it's generally sort of that amount of time people are spending, less than 90%, or it should be the best threshold for that. Consistent, longer duration or severity of desaturation, it's not really clear. But if you just look at the AHI metrics, this is clearly probably someone who's going to be at higher risk for problems than this person. This person may still be very symptomatic. Their CMS AHI is going to be very low. So if you're not doing something else to qualify, then get treatment. But if you just look at their AHIs on the face value, they're all the same. So I mentioned the comorbidities, they can have a heavy influence. So this was just a review of studies. Each bar represents a study. And this is some general prevalence data. This is before that latest Wisconsin sleep cohort. But you see some very, very high rates in certain populations. So the post-stroke population, we'll talk about these in some more detail. It's upwards 60 to 70% have OSA. The thought is now that, for a long time, it's chicken or egg. Will the stroke cause or sleep apnea or sleep apnea stroke? Now that's really, there's enough data supporting that probably these patients, you're looking at an enriched patient population that has had undiagnosed OSA for a long period of time and then had a bad cardiovascular outcome as well to that. So that's probably why the hit rate is so high in this population. And it's interesting, you look at them, they're not as sleepy, their BMIs are generally lower. So it's probably just people aren't suspecting that they have sleep apnea. But we talk about the other cardiovascular disease, coronary disease, congestive heart failure. This is kind of a misnomer. There's other, I'll show you some more data, but those are running around 40 to 50%, so very high hit rates. Those patients, type 2 diabetics, there's data supporting actually higher than this. These are two different studies using different methodology. I think one was a questionnaire based versus an actual objective, very high rates. Polycystic ovarian disease, high rates over 40%. Pulmonary hypertension, very high rates. COPD and interstitial lung disease also have high rates. The asthma, it's got a higher rate than the baseline. And atrial fibrillation, probably around 50 to 60%. And a lot of this is not just association, there probably is some cause and effect. And it's sort of coming around to most of it probably in sleep apnea is causing these bad outcomes, these diseases for a variety of reasons. So risk factors, we talked about weight already. For every 10% increase in your weight, there's a 6-fold increase sleep disorder breathing. One number is easy to remember, 1 kilogram per meter squared in BMI increases BMI by 1%. This comes out of sort of Wisconsin sleep cohort data. And then obviously you don't have to be obese though. I see a fair number of patients that aren't obese who have sleep apnea. It's particularly common in certain populations, particularly those of Asian heritage. So oftentimes you see nasal obstruction, enlarged uvula, tongue, tonsils, long, soft palate. retrognathias, I always do a profile on my patients, so what their gestalt does look like their jaw is set back, or is it small? That'll be risk factors, particularly, and if you look at non-obese patients, a lot of them will have craniofacial abscess. It's a high percentage. There's data supporting that. We talked about gender. Men are higher risk and for more severe apnea, but once women become postmenopausal, they're going to start to rise. Approach that of men. Age, we talked about. Family history actually is predictive. If you have a primary family member, your risk of sleep apnea goes up. I can't remember the exact number by which it does. Talk about comorbid illnesses, substance abuse, particularly things like alcohol. And sleep deprivation will make things worse. It's not going to cause sleep apnea in and of itself, but someone's teetering on the board, on the border, it may contribute to that. So a few years back, I had the opportunity to go to Hong Kong for a conference, and I went out to this island, and where they had this thing called the Big Buddha. I thought it was gonna be something really cool and ancient that somebody built. But turns out the Chinese government plopped this thing there about 40 years ago to make a tourist attraction. Wow, it's like a 60-foot tall. But not being Buddhist, I didn't know much about Buddhism. But so I learned that there's different variations of what the Buddha looks like. And so you got the heavyset Buddha, the thin Buddha, and as I mentioned, particularly in Asian population. So I have actually a fair number of those of Asian descent that are not obese, that have sleep apnea. Their BMIs are actually very low, and it just has to do with the craniofacial structure, the way that the mandible and the maxilla are. This guy.
Is there any studies that look into that relation with like type 2 diabetes in Asians, since they also get them at very low BMIs?
Yeah, I think there is some data. I don't know the details, but there has been. Yeah. So if you look at their prevalence rates, they're not as high as ours for sleep apnea, but they are higher than what you'd expect for the BMIs. And I think their cardiovascular outcomes are similar. So I know there's some data that's come out of I think China, Singapore, stuff like that. Yeah,
Interesting.
Yeah, and the risk is not there. So the issue with always with sleep apnea is how much is the obesity, but
Right.
There's a lot of pathophysiologic reasons. That you get the systemic inflammation, you get the hyperadrenergic state. These things impact insulin sensitivity. Yeah. Yeah. So there's this guy. Regis, yes. Regis Philbin, he's been diagnosed with sleep apnea, so he's not overweight either. He talked about it on one of his shows at some point. So this ASM, just a little bit of the pathophysiology. So we have hard palate, I'm sorry, maxilla, mandibula, soft palate here. Or sorry, hard palate, and then soft palate in the back. And then you have your uvula hanging down. This is the genioglossus muscle, which is really kind of the tongue, the base of the tongue. Epiglottis. Up here we also have the tensor palatini and muscle, and then there's also what they call the posterior nose. These are the turbinates. They didn't label those. I don't know why. So it's actually, we see a lot of patients with very large turbinates to be an issue. Epiglottis, and then your hyoid muscle. So this is in a normal supine state. It should be open, although you can see that just a minute, but there's potential for closure in a number of different areas here. So in a normal subject, so it's looking at awake and non-REM, this is looking at the pharyngeal muscle activity. So the tensor palatini kind of holds up sort of the soft part of the upper airway there. So the genioglossus normally is active, non-REM, it doesn't change, it's a normal individual. Tensor palatini is active, but not that active. And you go to sleep and its activity decreases some, and airflow is maintained awake and asleep. Patients with sleep apnea, so airflow is normal when they're awake, and you have the apneas when they're asleep. But the genioglossus muscle activity actually goes down. And interestingly, their tensor palatini activity, and so Dr. DeWald will give you guys, talk about more of this in detail, because it's their area of interest. But it actually activated more during the day because there's so much crowding of the airway to try and keep the airway open. It becomes very active during the day, but then once the person falls asleep, and then loses that stimulus, wakeful stimulus, and it becomes relatively inactive, then it's going to help predispose the airway to collapse. So these upper airway dilator muscles. So we have sort of explained to people, as talk about the airway being a tube, and you have muscles that surround this airway and keep it patent. You fall asleep, our muscles relax, everything narrows a little bit, but if your airway is crowded when you start, fatty tissue or retrosite jaw or whatever the reason. So those muscles relax enough to partially collapse or completely collapse the airway. That's kind of what you're seeing here. It's important to note that there's some muscle activity, so we'll talk about that in some more detail. So again, wakefulness, you're breathing normally, but you fall asleep. And if you're predisposed to sleep apnea for whatever those risk factors are, there can be collapse. And part of the problem with some of the ENT surgeries when they start talking about these things is that there's often multi-level collapse. So, for a while, they don't do it much anymore unless it's in conjunction stuff. They go in to take the uvula out, say, aha, I fixed the problem, I remove this obstruction, well, then they collapse the base of the tongue. Then you can go in and do some on the tongue, and then they may collapse higher or lower. And so there's all these, so it could be a real problem. So a lot of the ENT surgeries that are done that sort of simplify the old fashioned surgeries don't work very well. So you really want to have a good ENT surgeon that's not going to offer those things. Most patients. Someone's got a very low HI and they're thin and that's all that's going on, it might be reasonable to consider that. So we fall asleep. So you're starting with an anatomically narrow airway, and then there's loss of that neuromuscular compensation. The airway collapses, can be an apnea or hypopnea. Person gets a little hypoxic. CO2 also rises during this time. Increased effort to breathe because the airways collapse. And then the increased effort to breathe in the hypoxia or hypercapnia will stimulate an arousal. Brain wakes up, see on the EEG, signals get sent down to those dilator muscles saying, hey, we're not breathing right, fix this problem. Pops the airway back open again, so it tenses up those dilator muscles. Airway opens, and then because the individual is hypoxic and or hypercapnic, there's a hyperpnea, so there's overbreathing to try and compensate for what just happened. But then when you hyperventilate too much, right, then you actually drop your drive to breathe. There's a whole nother topic we'll go into control of breathing. But then you start getting this vicious cycle. So there's been some arguments back and forth, like Dr. Stroll wrote one of these pro-con debate things a while ago, about it's anatomic, and he's like, no, it's neurologic problem. It's really both, it's got a anatomic predisposition, but there's probably some neurogenic predisposition to this problem as well. And so we'll talk about that. There's loop gain, and then there's the critical pressures. So if this is too much, then you're going to actually predispose. You drop someone, they get they're hypercapnic, they hyperventilate, and they blow their CO2 down. That's going to predispose them to have an apnea then, because there's not going to be a drive to breathe. It makes the airway more prone to collapsing as well. So that was the ASM's version. This is my simplified version, which I made a long time ago. So glad to see they're in the same vein there. So airway narrows, collapse, hypoxia, hyperpnea, increased effort, arousal, hyperpnea, then decreased drive to breathe. And so you get this kind of vicious cycle that's happening. So there's been some pretty elegant work. So for a long time, we've sort of just got sleep apnea, you get CPAP. It's just the whole thing. You got sleep apnea, you get CPAP. That obviously a lot of things, work going on looking at alternative therapies, but when you use those things, and really there's been a sort of this growing interest in better understanding about the endotypes of sleep apnea. So what is actually driving the sleep apnea patient? So this is a very good kind of, I think, landmark article where they tease some of this out. The problem is that just to demonstrate also, why some people get sleep apnea and some don't. The problem with this is it's not super easily applied to a PSG at this point. So at some point hopefully we'll be able to do this clinically and say, okay, you have sleep apnea, it's severe, and the reason you have it is because your P crit is too high and therefore you need CPAP, or your loop gain is too high and therefore we need to actually set it as things like that. So what they did was they took individuals who had no sleep apnea, BMI more than 25, those that sleep apnea with the BMI more than 25, and then those that had no sleep apnea or control, so BMI is less than 25. They looked at the P crit, and you see the P crit. So this is the pressure of around the airway. So normally it's generally a negative pressure, right? So to get that, if it's a negative pressure in the airway, to get it to collapse, you're really going to take a lot of more negative suction to do that. If the airway is already positive, if the pressure in the airway is already positive, it's not going to take much vacuum at all to cause it to collapse. And a lot of patients who have sleep apnea, they're pre-kit. And this was Dr. Patel, Sushil Patel. You guys haven't met yet, right? He's been on vacation. So he did some studies with this. So he's got a whole lecture on this thing. But so patients with OSA tend to have higher peak crits, meaning that their airways, there's usually adipose tissue surrounding, causing pressure, making the airway more prone to collapse just to start with. So you compare it to those, it's similar weight, but don't have OSA, so peak crits are higher. Genoglossus activation is actually similar between those with and without sleep apnea, but it's higher than those who have it, who are overweight, but don't have sleep apnea. And then loop gain in the patients with OSA tends to be more negative than those that have sleep apnea. Meaning that they have higher sort of loop gain, meaning they're more predisposing, let's say on average, but predisposing themselves to like overshooting and then undershooting, and overshooting and undershooting. So like your thermostat will do, temperature drops, set the heat, temperature starts rising, set down the heat. So there's a slight, overshoot, undershoot. In patients with OSA, you get the same sort of problem with the breathing. But it becomes more pronounced when you have higher loop gain. It means that this is the excessive response.
Hyperventilation that you're talking.
Yeah, so they'll take kind of deeper breaths, they'll lower their CO2. Then the arousal threshold tends to, so it takes it's a more negative arousal threshold, meaning that they have to generate generally on average a bigger arousal to awaken them. So this may predispose why things will last for a longer period of time if the patient wakes up. Someone the higher arousal threshold, they may wake up just there's a mild perturbation in their breathing, whereas sleep apnea patient that they take more than that. So the people you're particularly worried about, the high peak crits, the genoglossus activation in these patients with very high arousal thresholds. These ones are patients, they may have to be set to 60% before their brain wakes up, or have a 20 or 30-second apnea before the brain wakes up. These are ones particularly you worry about in the setting of in the perioperative setting or giving them opioids or things like that. They're going to sedate them. It could potentially worsen these problems, make the airway more prone to collapse, reduce the muscle activity, suppress their arousal response. So not skipping a treatment because we're going to come back to that, but endotype determination. So as we mentioned, patients with sleep apnea. So if they're not, getting CPAPs usually, and because of insurance issues, most patients we have to just offer CPAP tests. But if they can't use CPAP or they refuse to, or whatever, then you can do endotype targeted therapy. So if there's the high peak crit, you could consider oral appliance or doing, really do P3s anymore. Poor pharyngeal muscle responsiveness, so hypoglossal nerve stimulator, unstable ventilatory control. You can try and stimulate them to breathe. Acetazolamide, oxygen may help reduce that. Low arousal threshold. Then it doesn't make sense now. Relax yourself. Yeah. Oh, so muscle relaxers that aren't they're sedatives that aren't gonna relax the musculature. Oh, this is low. This is not high arousal. These are low arousal threshold patients. So these are patients that are easily awakened. So they have hypopneas and they wake up. So this is gonna be more like women, and then because of that arousal, then they may have a loop gain issue. So it's usually this will be given in concert with this. This hasn't really totally taken hold. I think most of the time we're still going with our standard 3 buckets of PAP, oral appliances, surgical interventions. But as we get better at doing this, and I think more data comes out, then we probably will be able to offer patients these other therapies. And there's obviously, we'll talk about therapies. There's other therapies we consider as well. So this study did show that where they tried to endotype patient, they looked at their CPAP use at 1 month, that those that had a higher peak crit had higher pressure needs. That makes sense, right? So the more tissue you got to move out of the airway to open it up. Those at a higher peak crit and higher loop gain actually were more adherent. So they probably were benefiting more from the therapy by over half an hour. So that's generally considered to be pretty significant adherence bump. And then those at any of those things all had larger increases in slowing state. All right, so this ASM obstructive events, hypoxia, apnea, critical arousals, adrenergic pulses, daytime symptoms, and cardiovascular outcomes. So we're going to go through this in a little more detail, but these cyclical events that happen during sleep. So again, PO2 drops, CO2 goes up, and then you hyperventilate, cause the opposite effects. So what this can result is decreased oxygen delivery to tissues, so organ dysfunction. They get oxidative stress and inflammation. That actually leads to endothelial dysfunction, so that can cause a lot of problems with vasoconstriction. There's lots of data looking at right artery thickness or pulmonary hypertension, things like that. Hypoxia and hypercapnia cause pulmonary vasoconstriction. That leads to pulmonary hypertension, leads to right heart failure. So that's a common problem that we see in patients, particularly with bad OSA. Sympathetic activation. So this is just your epinephrine, norepinephrine levels surging up. That can lead to translate into daytime blood pressure. I'll show you some information on that, as well as arrhythmias and then toxicity to the heart cells. Then you have parasympathetic withdrawal, which increases their heart rate. The arousals can cause both these things. So you get that hypoxia. So this is getting back to that CMS thing I started to talk here. So you get a lot of these things from that, but just the arousals themselves can cause these problems, which can have some similar cardiovascular outcomes. The pleural pressure swings that can occur. So patients that are, when their airway collapse, particularly apnea, really, as they're continuing to try and suck in, they're generating bigger negative pressures in the chest, right? So that can actually then adversely impact the heart. So it increases the transmural pressure. So the heart actually, what the heart would prefer, so the heart's in there squeezing in this vacuum, right? The heart's in the chest cavity is, when you're breathing in, is negative. When you breathe out, normally it's just neutral. But the heart's trying to generate a positive pressure. So when it's generating positive pressure in here and it's generating against the negative pressure, it's kind of got to work against that pressure. It's got to pull against that. So there's lots of studies, and we see this clinically. You put these patients with failing hearts on PAP therapy in the hospital and stuff. Now they got positive pressure, they change their intrathoracic pressure, negative, positive. And positive pressure, the heart actually likes that. It squeezes a lot easier. After load reduction is what happens there. So when you're generating bigger and bigger negative pressures, it actually causes increase in the afterload. So that is probably one of the mechanisms, in addition to the other things, leading to why some of these patients develop heart failure. Aortic dilation, increased lung water, so increased pulmonary hydrostatic pressure. So more negative pleural pressures, just stuff, preload drops and you get fluid rushes into the right side of the heart and into the lungs. So there's multiple mechanisms. So inflammation, oxidative stress, sympathetic activation are all huge ones. Hypoxia is one, arousals is another. So I just have some dramatic slides here for when I get this talking to primary care docs. Right? So I emphasize things that sleep apnea kills people. So it actually does. So there's been a lot of studies. These are all prospective in design. You see they're various sizes. And you see the mean HI report in some of these studies, moderate to severe, generally 5 to 10-year follow-up. Hazard ratio for death over that time is significant for all of them. Depends again upon what definition you use and how the HI was defined. So in severe cases, obviously bad. But I like to highlight this study. This is a very well done study. So this is out of the sleep heart health study. So this study was different than the Wisconsin sleep cohort. So this was another huge study. But what they did here is they cobbled together a bunch of other ongoing community studies that were happening. They got these patients do in-home PSGs, and then they start gathering data and tracking these patients and just generate a huge amount of data. And so there's been all sorts of spin-off studies from this. But one was looking at mortality. So bigger than the Wisconsin sleep cohort, 6,000 subjects. And then one of the primary things here, as opposed to these studies, even though they had the mean HI here, the numbers that had HI more than 30 weren't as much as you thought. But this had over 300 individuals. So the dose response relationship, look at your HI. So this is mortality going out 10 years, normal, mild, moderate, severe. If you look at the 5-year survival, it's only about 85%. And it's interesting, so I put this in the context of some other things that we routinely screen for, some breast cancer, prostate cancer. Screens for those, there's guidelines about doing that. Sleep apnea is actually, if you have severe OSA, your mortality is worse than either of those conditions. yet. We don't currently, the United States Preventive Task Force, right, family practice. Somebody I can't remember. I have another slide I talk about. They don't recommend routine screening. So it's unfortunate. Who's this guy? No. It's counting on me, but yeah. It's Jerry Garcia. So Jerry Garcia, Grateful Dead. He died in his sleep at age 53. Had an MI. He had known sleep apnea and diabetes. Thought the sleep apnea part played a role. And John Candy, 43. Jerry Garcia, 53. So why care about it? What harms people? So there's for a long time, there was a lot of cross-sectional data, association, OSA, and hypertension. There's pretty good data suggesting cause and effect. Coronary heart failure, arrhythmias, and strokes. Talk about some more detail. This came out of Wisconsin sleep cohorts. Like I said, they did studies on people every 4 years, and they were tracking them. So one of the original studies, they said, well, let's see what happened to these people 4 years later, and they found it's your relative risk of developing hypertension, which they had a standard definition of that, either new drugs or like so many serial blood pressures are high. I can't remember the details. But if you get into the mild group and then this more moderate to severe group, your odds ratio of developing hypertension goes up over time. Now, what they did in this study and this sleep health study was that, they tell their primary care doctor to get sleep apnea, but they didn't tell them that you put on therapy. So all these patients are not on PAP therapy. So there's kind of a natural experiment. So one of the problems we mentioned, the autonomic effect. So this is sympathetic nerve activity. So you're awake, you're breathing normally, blood pressure just kind of clicking along, nice steady. This is probably like 110 over 60 or so. You fall asleep, and actually what happens normally during sleep is sympathetic nerve activity goes down, your breathing's normal, your blood pressure actually, there's this nocturnal dip in blood pressure, it goes down, heart rate goes down. So no sleep apnea. So this is kind of on the same lines here, baseline, but when they have their breathing and then they have an apnea, and sympathetic nervous activity is this is at the baseline. Because of this prolonged apnea, the sympathetic nervous activity starts going up, 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 up. Then they start breathing again normally, and then it comes back down. So there's norepinephrine and epinephrine surging during this time. What you're going to see is blood pressure ramps up. So this is an actual patient. This is during dream sleep. And you see their blood pressure here hitting 200 over like 90. This is during sleep. So not supposed to happen. Like I said, normally 110 over 60. It's probably dropping down a little bit lower than that, 100 over 50 maybe during sleep. So they've lost their nocturnal dip, but worse than that, they developed severe hypertension during sleep. And then it's thought that if this goes on, so you think about this happening, 7-8 hours at every 24-hour time period over time, it starts to translate into daytime issues. So this said, a similar patient put on CPAP here, breathing is restored, sympathetic nervous activity stable, blood pressure looks better. It's not totally normal. That's 150 over. So these were studies. During Summers, you'll hear his name kicked around a lot. He's actually a cardiologist, but has big interest in sleep at Mayo. And so he's done a lot of these. This is one of his early studies, but his name's on a whole bunch of stuff related to cardiovascular disease, sleep apnea. This is looking at sleep apnea coronary artery calcification. This is looking at HI quartile, so 10, 21, 53, so roughly mild, moderate, severe sleep apnea compared to no. And these are for controlling for different risk factors, which they try to, model, go for like 20 different risk factors. And, coronary calcification is a, correlate with severity of coronary disease. And here again, you see higher dose response relationship between severity of sleep apnea and the odds ratio of having coronary calcification. Again, this is sleep heart health data, cross-sectional analysis. Again, RDI quartiles. I'm not sure why they call it RDIs in these. They're home tests. Maybe that's part of the reason. When you get into the mild and then more moderate, looking at coronary disease, heart failure, and stroke. And again, this is just in a cross-sectional, so it's a point in time. It's not cause and effect, but showing an association between sleep apnea and all those things. When we look at heart failure specifically and breaking this out by obstructive sleep apnea and then central sleep apnea, aqua in the green. And more recent studies here included, because this was after they started adapting some of the newer medications, although they probably need to update this since we're using different medications now, but this was when beta blockers and aldactone became widespread part of treatment. But you can see OSA prevalence is upwards of 50%. So what's thought here is that, these are all different studies, that because all those reasons we talked about, the heart starts to get stressed and it'll start to fail over time, leading to obstructive sleep apnea in a lot of these patients. Once the EF drops low enough, and actually then they develop probably central sleep apnea. So central sleep apnea is probably a cause of low EF heart failure. There's a whole other talk on that. There's multiple reasons for that, but the obstructive is the obstructive sleep apnea is probably leading to the low EF heart failure. And then the low EF heart failure needs to central apnea. But if you have someone who's got significant, probably less than 35%, you're talking a hit rate of at least 60-70%. So like all these, you can go to cardiology. Everybody you see should have a sleep study, which I've done over the years to some success. And then there's also similar data. So if you look at HFpEF, heart failure preserved ejection fraction, it's actually quite similar. That the rates, the central apnea is not so big deal, but the rates of obstructive sleep apnea in that patient population is upwards 50-60%. And again, probably from prolonged and treated hypertension issues and treated sleep apnea driving. So it's very prevalent in that patient population. If you look at arrhythmia, Serena Mera, who was sleep fellow and staff, Cleveland Clinic staff, now she's heading out to Washington to take over their division of pulmonary out there. You'll see her name on a lot of stuff. So she did a study when she was a fellow. It was very painful. She took some of the sleep heart data and she went through all these EKG tracings from a whole bunch of studies, and she looked to see categorized by sleep apnea, no sleep apnea, looked at health, and they were having things. So you'll see a lot of this stuff, and I have a whole cardiovascular EKG talk I'll give you guys some point during the year, what you should look for, but seeing rates of atrial fibrillation during the studies, 5% versus less than 1%. If you don't have sleep apnea, you see a lot of PVCs, non-sustained VT. So these are probably the two biggest things. So we will see these pretty regularly. Clearly, there's an association, and it's probably going to cause an effect. The sleep apnea causes changes in the cardiac structure, the hypertension, how that can predispose to some of these cardiac rhythm problems. And when you look at atrial fibrillation, PSG diagnosed sleep apnea independent risk factor for atrial fibrillation after an ablation. So an ablation is where they go in and they zap the heart to try and eliminate some of the pathways that are contributing to it. And so if you do that and someone doesn't have sleep apnea, there's a recurrence rate of about 40% over the next year. They'll go back and they fit. If someone has sleep apnea and you treat them and you zap them, then the recurrence rate's about 40-50% over the course of next year. If they have sleep apnea and you don't treat their sleep apnea and you zap them, they're about 89% likely to go back into sleep apnea. So it doubles the risk of going back. So this is very powerful data. We took to our EP docs, said, hey, you got AFib patients. You don't want to be doing these procedures. You're wasting your time putting them through this invasive, aggressive, sedated procedure if they have sleep apnea and you're not treating. So a lot of EP docs won't cardiovert people without, or cardiovert or do a radiofrequency ablation unless they have a sleep study first to verify whether they have sleep apnea and they have sleep apnea, they know about treatment. So this is PSG based studies. You can see here the odds ratio going back to about 40-50% higher, 40% higher. This is a really fascinating study. It's a Viren Summers study. It came out of Mayo almost 20 years ago. They actually it's just kind of a neat study where they went and looked in the death certificates in the county that Rochester's in. And then they went to look, so these are patients that had sudden cardiac death. And they went back and they looked to see, did they have a sleep study? And if they had a sleep study, they have sleep apnea or not. And then they would see, okay, if they have sleep apnea, no sleep apnea, or don't know, when did they die during the 24-hour time period? And what you saw was the midnight to 6 a.m. shift. Sleep apnea patients twice as likely to die as those that don't have OSA or not known. So they tend to die at night. And they tend to die at night probably because some of those cardiac rhythm problems or stroke, heart attack that happened during the sleep. So, prevalent sleep apnea post-stroke, so we talked about this. For some reason, the neurologists and the stroke literature, they like HI more than 10. I don't know why, but when you use that cutoff, it's around 60%. And it's interesting, if you look at TIA patients, so patients that have had a transient ischemic event, no damage to the brain, their rates of sleep apnea are exactly the same as if we had a stroke. So that's one of the reasons why we think that the OSA is contributing to stuff. But if you go back, like you get a history, most of these patients had symptoms prior to their stroke. The sleep apnea does not get better the further out their stroke, with rare exceptions. They have like bulbar symptoms or something. But if you look at just use HI5, it's 70%, 30%, it's severe. I'm sorry, 30% will have severe sleep apnea post-stroke. So 70% will have at least mild sleep apnea. Interesting, central sleep apnea. So it's thought for a long time that if you had a stroke, oh, you're probably in central sleep apnea is related to brain damage, but that's pretty uncommon actually. Let's see that. That's more common if you have a brain bleed, not a ischemic event. Stroke TIA. So it's looking at hospitalization. So being hospitalized if you have sleep apnea versus if you don't. And this is 12 months prior to their diagnosis of sleep apnea, so they're not on treatment. The assumption, so there's been a lot of studies that have used this kind of methodology, because the assumption is if you have sleep apnea, you probably had it for long. This isn't something just pops up overnight. Most people have had it for years before they're diagnosed. So in fact, once they have their sleep study, they have sleep apnea or not, and they would look back a year prior where they hospitalized. They're 65 years old, cardiovascular disease is a large database, you have 36,000 patients. So much more likely the black is undiagnosed sleep apnea versus no sleep apnea to be hospitalized 1, 2, 3, 4 times compared to those that, so it's more than they're almost a doubling there than those that don't have sleep apnea. They're getting hospitalized for a lot of things we talked about already. Controlled hypertension, heart attack, strokes, AFib, diabetes out of control. Speaking of diabetes, it's an ASM slide. So again, upwards of 80% or so type 2 diabetics have sleep apnea, most have not been diagnosed. The ADA actually recommends, American Diabetes Association recommends that these patients should all be screened for OSA. You know, they don't say they don't need sleep studies, but at least ask questions, do an exam, or do a screening questionnaire. If they have high risk, then get a study. We know that because of some of the mechanisms we talked about earlier, that those things impact insulin sensitivity. And that gets better with CPAP therapy. And interestingly, those are the lower BMIs, which you're getting at, seem to have more robust response. I'm going to go into great detail about reflux. I was interested in this for a while. So it's thought that the negative pressure generating the chest predisposes to acid being sucked up from the stomach into the esophagus. Their lower esophageal tone tends to be lower. And so the problem has been teasing out obesity. It's a huge risk factor for reflux too, but consensus is they think that OSA probably is a contributing factor, and there's some data supporting that pushing people on PAP therapy can improve their GERD symptoms. And it's probably, there may be a two-way street here. It's a bi-directional thing, but that's not for another day. Then obviously these patients are sleepy, but not everybody is. Like I said, probably only about 40 to 50%. That can translate into reduced alertness and vigilance. Higher rates of motor vehicle accidents and work-related accidents, so there's big risk factors. And actually the trucking industry is on this. You will see patients that are sent to sleep clinic. So I get a decent number of these patients. They're some of the harder patients to manage because they get sent once if they have a BMI threshold. And we'll see pilots occasionally too, but really the trucking industry is all over this. They will send them get a sleep study. So you can't have your CDL until you get a sleep study. And then they're found to have sleep apnea. The patients come to see us and they're all pissed off because a lot of them don't have symptoms, so they feel fine and they're had a car accident. Why do I need this? You tell them they've got to be on CPAP and they can't get approved for their CDL till they're on treatment, CPAP and oral appliance, and they're complying with therapy. And they hate it, and some get very angry. I had some that refuse and go to further work. But there is data supporting that a lot of these patients, there's higher rates of car accidents and jog. So if they're in a safety sensitive occupation, it behooves you to discuss that with them. And kids, you'll hear more about this from John about school and work. Difficulty concentrating, reduced productivity, falling asleep in inappropriate social circumstances, all these things can occur. They're more prone to getting depression. There's a lot of data about depressive symptoms, and once on PAP therapy, it goes down dramatically. It doesn't necessarily mean they had depression, but they have symptoms that can mimic depression. Some do have true depression. anxiety, irritability, social and sexual dysfunction. So erectile dysfunction is common in men, low libido in women, sleep apnea. So we kind of think about these things as being chronic sleep deprived states. So for the men, some it's vascular mediated, but a chronic sleep deprived state will affect these things. There's a body of literature about neurocognitive impairment, including actually impacting. So when you look at MRIs, there's white matter changes that occur in these folks. And part of the problem is that it's not always reversible. Sometimes it is. So it's not a guarantee it will get better. We get patients referred from neurology occasionally, patients having memory problems, possible dementia, so sleep apnea contributing. Sometimes treatment helps, sometimes it doesn't. So that can impact the learning and memory, attention, information processing. There's actually some data about emotional intelligence, visual, psychomotor performance. All these things are very important, not just for daily functioning, but particularly in certain job situations. There's also some patients you will see patients that are sleepy and they're persistently sleepy despite treating their sleep apnea. So you get them on treat sleep apnea. You got their CPAP and looks great. Their download's good. Say confirmatory test, still looks good. They're sleeping enough. There's no circadian rhythm problem. They're having leg problems. There's nothing else going on, and they're still sleepy. So the thought is, and this often, not often, but it does occur in some patients who have severe OSA where they've had hypoxia and damage to the reticular activating system. So that's the center for wakefulness, and if that area gets damaged, it doesn't matter. We treat their sleep apnea; they're still sleepy. So we do. There are patients, and there's FDA approved, like modafinil is FDA approved for these patients to treat residual sleepiness related to sleep apnea. So it's not a substitute. They still need their PAP therapy, but they may need stimulants to help keep them awake despite adequate treatment of sleep apnea. That's a whole other topic too. All right, who's this? Yeah, I get yelled at. She's not on the view. I did this during one talk, so she's not on the view. Yeah, so she's been diagnosed with sleep apnea. She's been publicly open about this. She's still alive. All right, so what should we care about is underdiagnosed. So we talked about the prevalence rates earlier. And again, that's very conservative measures. This is a study we did at Metro a number of years ago. So there's a lot of reasons it's underdiagnosed. This is not unique to Metro, and there's been a bunch of studies looking at this different methodologies. But I just had one of our residents go into the family practice clinic and pulled out new patients coming out after their visit, and we had them just fill out this stop questionnaire. Really do a stop bang nowadays, and then the Berlin questionnaire. Both those kind of have positive predictive values, around 0.85, 0.9%. So meaning that if you're positive on that, it's 85-90% chance you've got sleep apnea. And then we went back and looked in their medical record after the visit and say, okay, did the doc ask anything about? These are all new patients asking about sleep apnea, history, physical exam, review of systems, past testing, anything like that. And they uniformly did not. So about a third of the patients considered high risk for sleep apnea. There's only 2%. So someone did actually ask, and the other one, they had no diagnosis. So they were just missing a lot of patients that had sleep apnea. Again, it's not unique here. There's a bunch of chart review and other database studies, things like that, showing this kind of universal. So it used to be the quote was 90% of patients who haven't been diagnosed. It's down to probably 80% or so, but even more recent data suggests it's probably still a huge number. It's probably around 70 to 80%. So it's way underdiagnosed, despite all the referrals we get and all that. So that's why we have to go out and sometimes push this on people, say, hey, you guys are missing this, it's important. We see certain practice patterns, certain providers are very tuned to this, and they send us a lot of referrals, and some just never send us in. Then I missed the study we did in the inpatient setting. Again, similar sort of thing, but this time we just did PSGs on random patients admitted to the floor. And we found that actually about 40% had moderate to severe OSA. These are patients just coming in for cellulitis or GI bleeds or mild GI bleeds or asthma exacerbation, whatever. They weren't coming out of the ICU. We randomly selected them. Their BMIs were only like around 30 or so. Found out 40% had moderate to severe OSA. We brought some back for studies outpatient. They all still had sleep apnea, so it wasn't just a hospitalization effect. It's very hard study to do. We did about 90 folks. Only went back, looked at the charts. Only 2 were suspected about it. The primary teams take care of the patient, so they miss it all the time too. we're generally tuned to this in certain areas of our hospital. We'll look for it pretty aggressively in those patients. It's
Have
very,
you guys found the sleep studies with for this?
this study, yeah, we had some money to do this. Because these were full PSGs who were attending at the bedside. What's that?
Did you?
Oh, yeah, they had to consent. Oh, yeah, yeah. Yep, yeah, they had to provide informal consent. Yeah, we randomly selected, we had a study coordinator who screened charts. We did like Monday through Thursday nights, they screened charts and then just patients that were newly admitted, and then they approached them, say, hey, we're doing a study, we're like, see if, would you mind doing overnight sleep study? And our tech would come in and set them up.
Those telemetry are like really easy to pick up.
Was that telemetry?
Those are.
Yeah, well, these were general medical floor patients. If you do, there's certain areas of the hospital that are gonna be really low hanging fruit. So like I said, the post-stroke. If you go into your cardiac tele unit, if you go into CCU, our step down unit, you know, this probably well over half the patients have sleep apnea, most are diagnosed.
These patients were reporting symptoms or?
Some did, some didn't, yeah. So we did 2 questionnaires, that's another part of this study. The questionnaires didn't function quite as well, so. But, so again, you know, if you use HI5, it's like 70%. And I don't remember what the correlation was with symptoms with those folks, but if it's 15, you don't even have to have symptoms. So, yeah. So again, who should we screen? Only when we or the patient think of it, and we know that that fails routinely. I used to have a neurologist here, no longer here, who would only refer patients if he thought they would use CPAP. Really stupid. Those in high-risk groups, which is certainly a good place to start, you know, everyone, but yeah, CDC, USB, so they don't recommend screening. But like I said, when you come from our perspective, we say everybody should have a sleep study.
Well, so we routinely send people to sleep medicine. I'm feminist.
Yeah,
If they have resistant hypertension, what is resistant? More than 2 hypertensive
Yeah.
medications.
Yeah.
So then it's like, okay, you're on 3 drugs and not a whole lot is happening. So go do
Yeah.
your sleep study.
right.
And then, oh, I don't know, blah, blah, blah. Then you do a family collateral. Oh, yeah, he stops sleeping.
Yeah, yeah.
Like kids, right? And so
Yeah, a lot of-
we do that for sure. And AFib. When I did my sleep medicine rotation, 1 day a week, our sleep doctor went to cardiovascular center. And so they just gave anybody with AFib. Just the cardiologist would refuse to do like a second ablation and they go
Yeah.
to treat their sleep. Because some patients like, I don't want to wear it, just ablate me, I'll be fine. And then obviously a year later it comes back and then like, I'm not doing this again until you fix your OSA. So there's this really good beneficial relationship that we had. So what I'm trying to say is that not all PCPs are the same.
Oh, I know, yeah, no, that's what I said, we have some that are very tuned and refer
Yeah.
regularly, and we have some that never refer. So that's why we just kind of have to routinely get the message out. It took a while to get our cardiologist on board, I had to hammer them for a long time, but now they're actually pretty attuned to it, and they will send us a lot of referrals. But this is part of the problem, is that they don't recommend, a lot of these big societies don't say you should routinely screen patients for sleep apnea. Clearly, I think anyone with a lot of, and we'll talk about what the ASM recommends, a lot of these high-risk groups, yeah, I mean, somebody should be asking questions, it's just they slip through the cracks, a lot of people don't think it's their responsibility. I'm not slamming primary care at all, I'm just saying that this, you know, there's a lot of reasons for it, it's, you know, the patients don't bring it as a complaint, because they're, you know, if they don't have a bed partner, it may not be an issue. Some docs just aren't aware of it. They don't have time. We're all under huge time pressure. They got to take care of 5 other problems. Last thing we do is act with their sleep. Particularly the patient says, "Well, I can't sleep. It's insomnia." And they're like, "Ah." You know, and then maybe there's logistic hurdles in terms, you know, if it's too much of a hassle, put a referral or whatever it is. There's a lot of reasons why. There's a lot of barriers to, you know, getting these patients evaluated.
But it's getting traction.
Yeah, yeah.
And it's just stated blankly that like 40% of hypertensive patients will have OSA, so we are sort of.
Yeah. Yeah, so I mean, it's spreading, yeah, it's just, this has been, I'm talking about over, you know, 26-year career here and going back to stuff and what's needs to be done, and we still see issues, because I see patients and I'm working my way out of inpatient, but I still was doing inpatient very recently, and you see patients there all the time just having a diagnosis. So it's just like, it's a no-brainer. It's obvious the patient has sleep apnea. You just gotta ask a few simple questions, put it in your chart. So, okay, you need a sleep study in order, but it's like, this patient's been, being seen for 25 years, and why didn't anybody else pick this up?
Because pretty much like 90% of the time, somebody comes in with HHS,
Yeah.
EPA, and they're all inflammatory, like our hospital overused. And you could see it, like, this is an OSA patient, you send them, they'll be positive.
Yeah.
And they never said, oh, yeah, you probably have OSA, and this is the
Yeah.
end of it. They never refer or recommend it or
Yeah,
anything
so
at the
they-
discharge.
Yeah, a lot of times they'll talk to your doctor. They don't want to take responsibility. We had problems with that
They just
before.
don't.
They were always afraid if they ordered the study, they would get the report and they'd be responsible for doing so.
Exactly.
So we had to tell them, no, we'll take care of it, don't worry, just order it. Yeah, we talked to them about it as well.
Do you guys do an echo group with PCPs here?
In Echo Group,
Yeah, like, just like general, like subspecialty basic training for them?
oh, we do, so we're actually having a sleep symposium first,
Oh.
whenever this spring, but we did one probably 15 years ago, and then they have these lunch and learn sessions.
Yeah.
We sometimes do those, yeah. Yeah, so it's been slow, but yeah, the word's getting out. So all these, so the ASM, what they recommend is screening, the primary care providers screen everyone's 18 and over with all those things we've already talked about. And actually, they did say resistant hypertension and pre-op for just bariatric surgery. They recently updated it to include all these things, plus craniofacial abnormalities we talked about. They have sleep complaints, sleepiness, obviously. Not just resistant hypertension, but hypertension, pregnancy, which we're not going to get into today. I got a whole hour talk on that. And any surgical procedure, which also there's I got hours of talks on periop, because that's one of my areas of interest. Periop risk with sleep, undiagnosed sleep apnea, and that's actually been something that's the whole pre-op arena and screening patients coming for elective surgeries sort of push some of this forward. But they recommend that these patients all be screened for sleep apnea, which after what you've heard, hopefully makes sense and should be straightforward. You know who this guy is? Football fans, Reggie White. He was a all-pro linebacker for the Green Bay Packers. Died again, age 43. Not particularly overweight. He was a muscular guy, very fit. He had sarcoidosis and sleep apnea, but he died in his sleep also. So probably a combination of the two did that in. So NFL players, this is old data now. But the interesting thing is, so you're looking at young guys, average age 25 here. So most of them been talking about a lot of older folks, right? So young guys age 25, look at their neck circumference is 19 inches, BMI is 36. So high rates of sleep apnea. So this is 14%. I think this is a very conservative definition. That's like prevalence in general. But again, this is a very young population you're talking about here. So it's probably higher now if these folks. All right, so symptoms, you guys should be aware of this: snoring, choking, gasping. Witnessed apnea is probably the most predictive, actually. If bed partner says you have witnessed apnea, they're almost guaranteed they have sleep apnea. Snoring, it's really needs to be kind of loud snoring. Large portion of the population snores. Many of them don't have sleep apnea, but if it's loud or intermittent, you can hear it through closed doors. Difficulty maintaining sleep. So it used to be thought that insomnia, so just tell you a real quick aside, if you had insomnia, you never got sleep studies. That was kind of the rule. Actually, the ASM said back in the 1990s, insomnia, don't do sleep studies. And one of my mentors, when I was doing my training, we were having a group, our case conference thing, and we were sitting around talking. I was in training, and this guy said, I'm going to get a sleep study. And I was like, what are you doing that for? She got insomnia. It's like, no, I think this guy's sleep apnea. And I think sleep apnea is causing insomnia. Like, you're crazy. So he did. And then he actually published a whole bunch of series and the whole thing about this coesa now, so comorbid sleep apnea and insomnia. So now it's a well recognized thing, actually, that insomnia, if anybody presenting insomnia, one of the first things you should do is screen for sleep apnea. So both sleep onset and sleep maintenance insomnia. And actually treatment can help those things out. So the patient that may be their primary complaint is insomnia. And then daytime symptoms, morning headaches, sleepiness and fatigue. We talked about that already. Talked about those things, impaired quality of life. The association, if they complain a lot of GERD, particularly at night, hypertension, we talk about panic attacks. Some literature about seizures, particularly nocturnal seizures, poorly controlled seizures. You have to think about sleep apnea, potentially men. So the physical exam, we pay a lot of attention to head and neck. You guys will probably hear more about this as we go along, so we get into clinics. The nose is very important. Our ENT docs have talked on just the nose and sleep apnea, but looking for septal deviation, crowding of the turbinates. Oropharyngeal space, soft palate, tongue, tonsils, adenoids, teeth, are they dentition? How are they in repair? Assessing the mandible again, I always do sort of profile shot, get a gestalt, thyroid, signs cardiopulmonary disease and hypothyroid. Interestingly, if you have hypothyroid, your risk of sleep apnea is higher than the general population. If you have sleep apnea, your risk of hypothyroid is not higher than the general population, but there is still an association between the two, particularly if the hypothyroid is very profound. So I always do note if someone's had a TSH check, but I don't routinely send it on patients. Let's say I have signs or symptoms. It's the ASM, so they also pay attention. I didn't have on my slide, which is neck circumference, a little more detail in the upper airway. So lateral wall crowding. So interestingly, it actually does tend to be more lateral collapse on a lot of patients. High arched palate in particular. So the palate gets high and then it tends to dive down deep posteriorly. So that could be a risk factor. The tongue, so you'll see a lot of scalping in the tongue, which means that their tongue's kind of pushing up against the ridges of their teeth and it gets ridged. So you're gonna pay attention to that. A lot of patients have very large, bulky tongues. Some of that's fatty deposits, some is just the way they're made. Large uvular tonsils, and the modified mound patty, which I copied their slide, but I'm not really happy with it. So the way I usually do is just ask them to open their mouth, then protrude their tongue. They actually have them in the modified mound patty, then protrude their tongue. And this is mostly based on looking at the tonsillar size. So they have 0, 1, 2, 3, and 4. So this is kind of more tonsillar grading. We don't see patients in the adult world that look like this very often. It's pretty uncommon. The mound patty that we use is looking, so when you look back there, you should be able to see uvula and then some space and then the tongue. And that's class 1. Class 2 is where you're just seeing a little bit, you can see just a little bit on the sides of the tongue, sort of between the lateral walls. You don't see the tip of the uvula. There's a little space there. So that's class 2. Class 3 is where you're seeing tongue and soft palate. And there's a class 4 where you see tongue and just hard palate. And so you can't see anything. You'll see some of these patients when you get into with a tongue depressor, you can't see anything. You're like trying to mash that tongue down and they start gagging. You can't see anything. But it's a good way. So this came out of anesthesiology, but it's a good way to sort of grade things, and it does, suggest risk. The higher the mound patty or modified mound patty, that way it's probably more useful in kids or adolescents. Is the higher the risk of sleep apnea. So most of our patients that are going to be referred to us are going to have sleep apnea, 90%. So a lot of these screening tools aren't such a big deal, but they're bigger, utilized in other settings. So questionnaires, the good thing about questionnaires, if you can protocolize this in a setting, is that at least it gets them checking. So all the times when we're relying on us or the patient and we miss sleep apnea, if you protocolize questionnaires, you're going to capture a lot of patients that otherwise you would miss. The problem is that there's a lot of questionnaires out there. The test actually is variable. There's quite a bit of heterogeneity. All tools have high false negative rates. So you have to be careful. So it means that they have a high, if they score low, I always have to put them in clinical context. It doesn't mean they don't have sleep apnea. So in particular, we did a study a long time ago, just looking at our bariatric patients and looking at how they scored on the Berlin questionnaire, and then they compared their PSG, and the negative predictive value is very poor. So most everyone said that they didn't have symptoms or fall into a low risk category still have sleep. 78% have sleep apnea. When you have that kind of prevalence, the questionnaire is why you don't need to do one, just go straight to the test. But it's a problem across the board. So I always put this in clinical context. My clinical suspicion is still high, and I had a negative questionnaire, I would still do a test. My clinical suspicion is kind of intermediate or low, then I might stop. Screening's better than not. We've used the Berlin and the stop bang. Berlin's been validated in a number of different settings. The problem is it's very cumbersome because you got to do some calculations with it. Dr. Stroll was instrumental in this a long time ago. Then an anesthesiologist actually developed the stop and stop bang questionnaire. I'll show you what that looks like. It's easier to utilize and it actually has some discriminating value. So it's really kind of hot and fire. It's used most places in pre-op screening, and a lot of places are using just a standard screening process. So it's very easy to use, validated in a number of different settings. So this is what it looks like. It's just asking, do you snore? And the snoring here is loud enough to hear it through a closed door. Are you tired? So it's gonna be tired, sleepy, fatigue. Anyone seen you stop breathing and say, oh, do you have high blood pressure? That's the P. And then looking at the BMI, age, neck circumference, and gender. So there is a little gender bias here. If you're male, you automatically get a point. You just need, and you have to measure neck circumference. So all the rest is just a few simple questions, and then just some demographic information. You just got to measure neck circumference. So initially, when it came out, it was 0 to 2 was low risk, and 3 and above was at risk. Then they further defined it to 3 to 5 is now intermediate. So it's kind of a gray zone, so you can clinical correlation. But 5 or more is high risk for moderate to severe sleep apnea. We've started bringing this out in our perioperative pre-ops screening clinics. Our surgeons are real happy because most of them are 55-year-old men with high blood pressures. They're already all of them were scoring it here. But this is a nice study up from Bob Carney and Intermountain where they looked at patients who had sleep studies, stop bang questionnaire. So the group that sort of separates out here is this is a group with 5 or more. No, I'm sorry, it's severe sleep apnea. So stop bang score here, and then this is the no sleep apnea, mild and moderate, and then severe sleep apnea. So if your score is 5, likelihood, not having sleep apnea. So over 90% had sleep apnea, of which 60% was severe. So that was just a group of 5, and the higher you went up, the more likely it was severe. So it does have some discriminating value in terms of the values. So I think it carries some weight over some of the other ones. Yes. She's been diagnosed with sleep apnea and talked about it. All right, so I'm just going to talk about this briefly. Pick up the pace a little bit. So this was a study. Unfortunately, I was added onto this task force late in the thing, but I was happy to be part of it. Where we did the diagnostic testing for obstructive sleep apnea. So this is a good article. You guys, when you have time over the course of the year, you want to go to look at the ASM, look at all the practice and do those as well. They're important for board stuff, but also just important for what's the standard of practice in the community. You'll see that if you ever get involved with these things, they're very laborious to do, and you come out, you're trying to look for good data, and there's a lot of stuff we think, you just read the literature, oh, this is great, it's great, it's got to be. Look at the actual, put it to objective qualifications, a lot of it's not that great. But anyway, so this was a task force in which we tried to look at how we should diagnose sleep apnea in patients. So Vishesh Kapoor is at Washington. He's a big names on the board, and you'll see his name over a lot of the epidemiologic stuff, sleep apnea. So I would encourage you to go read it. I'll talk about the recommendations briefly, but basically, so this was also when is a PSG versus a home test recommended. And at that time, we came out, if you had certain risk factors, so particularly if you're at risk for hypoventilation or central sleep apnea, most of the home test devices aren't very good at detecting those things or discriminating those from obstructive events. So if you had those things, we said definitely need to go to get a sleep study. So you have to have signs and symptoms of moderate severe sleep apnea. And then if you don't have any things, or if you have any of those things, you need a sleep study. If you don't, you can consider a home test. At this time, the main home tests were just flow-based. There were some simple flow-based ones, and then the watch pack. We'll come back to why it's important in a minute. Then if you got a diagnosis, then start treatment. If you did not have a diagnosis, then you could consider additional testing depending upon the clinical scenario. So the problem with the home tests are that they do tend to underestimate sleep apnea because most of them can't tell you if you're awake or asleep. So you're taking those number of breathing disturbances, like I said, for PSG, it's by hour of sleep. For a home test, it's by hour of reporting. So you undercut things automatically right there. And then they don't measure sleep. So you're missing all the events with arousals. So in certain populations, which is a study I want to do, is to look at our HSATs and compare men and women. So I think we're doing, so we always put a caveat if their HI is low, but they have symptoms, think about or their REI or home test is low, symptoms, go ahead and maybe think about doing it in an in-lab study. We find a lot of them turn positive, you do it in lab. Because you're picking up arousals and you're dividing it by sleep time, not recording time. So you may need to go on and repeat a study, so it all depends upon a number of factors, or think about other sleep disorders. So the reason I brought up the HSAT is so they reconvened a small group of us, which I made the mistake of saying yes to this, just to look at the HSAT devices, and you'll see with the HSAT devices, they just totally exploited with technology, and it's a mess. So I know what to do. So trying to update guidelines for HSAT devices in terms of which ones can we use and when should they be used? Because we were pretty conservative in this recommendation. So PSG, you guys are going to hear more about this. So the best things about it: comprehensive data, 15 channels, determine relationships, stage of sleep, body position, etc. Someone's there observing this test, they can troubleshoot, make adjustments during the test. Problem is, it's still very costly. There is still limited access most places. Our wait list, and it's kind of bad, is 2 to 3 months for most patients to get in for an in-lab study, despite we have 16 beds. And they have to sleep in the lab, and some patients can't sleep in the lab, or they don't like to sleep in the lab, or can't sleep with someone watching them, they don't know. So there's problems with that. Home test, the benefits of these. So generally they monitor 2 to 8 channels. They're much less costly. They can be done in the home. That's what they're usually done. Disadvantages, limited data. There's no technical support. No one's watching these real time. So if a lead comes off, you just lose the data. Oximeter falls off. Test is no good. Flow sensor falls out. Test no good. You got to repeat it. So if you have technical failure, was it a patient problem? Was it a machine failure? Do you have to repeat the study, or should you just bring them into an in-lab? Those are all things to consider. Particularly now, they're not standardized. Some haven't been validated. Some have been validated very poorly. And then the technology they use to measure events is not always standardized, and so it's a problem. And then there is a non-trivial false negative rate. So in general, what it says, probably about 15% of these are technical failure rates. Is probably higher in our patient population, just because they're poorly educated. Have trouble with instructions, despite we give them first instructions, written instructions, and video links. We still see people that can't do it. And then there's probably about another 15 to 20% that are false negatives. So there are some problems recognized with these devices. Things will probably get better with technology, but it's not. So dealing with suspected sleep apnea, you don't do these if you suspect other sleep disorders, right? You think someone's got a circadian rhythm problem, a movement disorder problem, even for insomnia, that's actually a reason not to do a test. You don't want to do it to these patients. Or if you think they have narcolepsy or REM behavior disorder, anything like that, this is the wrong test to do. So we mentioned those at risk for hypoventilation and central sleep apnea, so low EF heart failure, hypoventilation, bad COPD, neuromuscular disease. Those can't follow instructions, so don't do it in this place. These are the ones we use, and these are kind of more traditional ones. So the Embletta, I like this one. It's just more cumbersome for the patients because there's 2 belts, a couple more things to plug in, but we get an EKG tracing with this, so I like that. And the signals I think they're easier to manipulate, they're much cleaner. It's just, we've had problems with interfacing with our SomnoAware system, and the patients don't more trouble with it. So we do much fewer of these. Our workhorse is kind of this Apnea Link, which is a very simple screening tool. It just has 1 belt. It measures the O2 sat, effort to breathe, effort or flow, and a heart rate. You don't get an EKG. So for most patients, it's okay, but for some, it's not that great. And then the WatchPat, which uses photoplethysmography and amplitude changes in the vasculature. So it's a little black box, and there's some additional, so it's called PAT therapy, peripheral arterial tonometry therapy. So the PPG is used for the oximetry, and then the arterial tone is used, and it uses this complicated, algorithm, which I don't think any of us really understand, to determine, if there's DSATs, is it tagged with a change in tone, and then that can be tagged as a respiratory event. It's actually trying. So it's really weird. So it's just doing this very simple patient to use, very easy. It's probably more expensive for a home testing device. Now disposable ones actually. Take it home, sync it with your iPhone, and then you toss it. So it's kind of a no-brainer thing to do. But I'm always a little suspect in these, and there is some more recent data that came out after we did this study suggesting they may not quite be as accurate as we originally thought that they were. But it's a lot of, they are popular because they're so easy to do. But when you look at these, it actually will give you a readout of sleep based on arterial tonometry and stuff, you know, like what stages, when they're asleep, what stage of sleep they're in. So there are a lot of different studies to look at. I'm kind of lukewarm on them. I'm not a huge fan, but there are people that are huge fans. Some people don't like them. If they have bad vascular disease, calcifications, bad arrhythmias, they don't work that well. Alpha blocking drugs, they don't work well. Yeah.
Brain syndrome.
Yeah, patients like that. So, but these are some of the newer ones. So this is actually Dr. Chang. He's going to give you guys a talk. So he's on that same task force with me. And he's a real content expert in this area. He's been on the emerging technology group of the ASM, which is also looking at some of this stuff. But he gives a very excellent talk, very complicated talk on all these things. But you can see, so there's a flow base at your traditional ones, and they're trying to make them simpler. This one's got actually a little canyon, can't see there. The PAT base, so there's the watch PAT, but there's all these other ones now. Peripheral arterial tonometry. Just the photoplethysmography based one. Just ones that are simple rings that you wear on your finger. There's just simple effort based ones that like fit on the chin. These acoustic based ones, which are based on snoring, vibrations, and how good these are. You know, that's what we're trying to look at. So we've done the literature search, trying to look at some of these things and trying to determine, you know, but a lot of these things have been just poorly validated, or they're validating against HSAT devices, which aren't as well validated. They're not compared to live TSG. There's mattress things you can put on your mattress, just a pad.
Yeah.
It's supposed to detect sleep apnea. There's infrared scopes, that's not even on here. That thing up in the corner, and it through some sort of like radar or sonar, it can detect apneic events at the nose and mouth. So there's all sorts of technology coming out. And the problem is things are coming out very fast, and then there's whole issues with what's FDA approved, what's FDA cleared, what's just out there being marketed without that. It's a big mess. I think as soon as we publish this, it's going to be out of date. You will see oximetry still used some places. You cannot diagnose sleep apnea with this, but you can sort of risk stratify, which is the way that we sort of do these. We used a lot of these for a while here, particularly in the inpatient setting. Patients, we say, okay, you probably have sleep apnea. We didn't have limited channel testing devices, so we just do oximetries on them. But these are not accepted by any insurance to give people therapy. You can't differentiate obstructive versus central. I talked about those patterns that are sort of classic, but it turns out they're not as clear cut as we thought. And so if there's been a push on and off, depending on people get real excited, oh, we should do oximetries, people don't. They're really, really cheap. They're easy to do. It's just a pulse ox, just download it, and then you can look at it. I showed you some of those oximetries from before. So one of the caveats is if someone's got a lot of symptoms, our oximetry is normal, doesn't mean they don't have sleep apnea. They could have all arousal based sleep apnea. So I've seen pretty normal oximetries where their ODI on their oximetry is very low. But you bring in the lab and their HI is like 40 because they're waking up all the time and not desabbing. So they can be performed anywhere. Again, very limited data, no tech support. Interpretations isn't standardized. So one of our old sleep fellows did a study with Stroll where he came around and gave all of us a bunch of example oximetries and all the UH and the VA staff and asked us to interpret them. And then what would you do based off this? It's just like all over the map. So they worked for a while. And one of the other fellows was trying to develop a standardized, I think they may have one a UH standardized way of interpreting these things. Again, non-trivial false negative rates, formal diagnosis can't be made. So suspected sleep apnea, I really think about these as risk stratification. So I still occasionally do them in the hospital. We do them for our post-stroke patients because it's a simple tool. And our post-stroke patients that get PM&Rs at a different hospital, so we can't really go over and set them up. But they can do oximetries there. So they can look and see if someone's again, it's everything's clinical context. But if they're really desaturating, if their brain's trying to recover from a stroke and they're really desaturating, they're high ODI, and we move a lot faster on that patient than someone else. Smartphone, this is just one, so FDA cleared. Just your phone, put it by on your night table based on your snoring and they'll turn whether or not you have sleep apnea with supposedly some degree of accuracy. So in 2017, we came to the conclusion that questionnaires, screening tools, algorithms don't diagnose it in the absence of objective data. So you can sort of get someone risk stratified, send them for a test. We recommend a single HSAT was negative, inconclusive, or technically inadequate. We do go on to doing a sleep study. Occasionally, we will repeat an HSAT, but a lot of times we don't. We did recommend PSG over HSAT, particularly in those, again, reasons we talked about, risk for centrals or hypoventilation. So that includes opioids. Also, patients with really bad insomnia, HSATs probably are not that great because you're not measuring sleep. So they can put it on, lie there for 8 hours, sleep for 1 hour or something like that. And their REI is going to be 2, and you bring them into the lab, give them a set Ambien or something or whatever, and they sleep for 4 hours, and you see that, or they just sleep for that 1 hour, but their AHI is actually much higher. So a lot of reasons. So you always have to put this in clinical context. Split night for PSGs is appropriate. The data wasn't great, so we got a weak recommendation. Occasionally we'll have a negative PSG, and if you still have very high clinical suspicion, you get a second study to really rule it out. So there can be night-to-night variability, which you talked about. Again, put everything in the clinical context. Some patients just don't sleep very well in the first night of the lab. They may not go into REM sleep, may not sleep on their back.
Is there a certain time frame that's recommended or required by insurance between the first and second PSG?
No, some insurances won't approve it, but usually a lot of times they'll approve like 2 within a year, but there's not a time frame that has to be done. But again, your clinical suspicion to be pretty high for those patients. All right, so we'll move on to treatment. So there's a lot of treatment things to be done. There's conservative measures, weight loss. We'll talk about in more detail. Lateral positioning, elevating the head of the bed, avoiding upper air irritants. So just smoking actually causes some upper air inflammation, narrows the airway a little bit. It's bad. Nicotine causes sleep fragmentation. That's bad. It's more they're awakening, even just brainwave awakening, that's going to predispose to loop gain issues. And minimize, these patients not going to be getting benzos. You can avoid opioids. Good idea. And then we talked a little bit about just risk patients in high risk jobs that you want to give them counseling about not driving drowsy, if they're operating a tow motor or something like that, or brain counsel about these sort of things. Flying. ASM, they said this in their broad thing. So almost all these are not going to be done as therapy by itself. These are things in adjunct to more specific treatment. Unless somebody got very mild sleep apnea, say AHI 7, and they really don't have any symptoms, they're not hypoxic. Yeah, you get weight loss or some very simple, try and stay off your back or whatever. Stop smoking, and we'll just monitor you over time. But by and large, most patients are going to need some other specific therapy. But losing weight, exercise, when alcohol and sedatives, sleep deprivation. We talked about supine positioning. So about half patients get worse when on their back. It's just a gravity effect. You can get them off their back. We'll talk about positioners. You tell them to just stay off your back, it usually doesn't work. Stop smoking, clear nasal passages. Don't get them started on Afrin to use every night. Usually nasal steroids if they've got big turd nasals. They have mild sleep apnea, that can actually work fairly well.
Is singular ever recommended in the adult population?
No, it's just peds, yeah. Unless we're treating some.
Yeah.
It can be used for allergies, but it's a
Right.
Yeah, don't worry about it. Yeah,
Okay.
I mean, but I wouldn't use it as a standard.
We use
There-
a lot of kids.
Yeah, there is data about nasal steroids in adults if they have mild sleep apnea and they've got chronic congestion issues and like turbinate enlargement. If they use it religiously, there's a percentage of them that will respond.
Right.
But again, everything in clinical context. So just this caveat on weight loss, because we'll talk about that the newest exciting thing in sleep medicine. You guys will be hearing a lot about this year. But this is just like, this is a meta-analysis on bariatric patients. So just to point out, highlight a couple things. These are patients, this is their baseline BMI. So these are really overweight, morbidly obese. The average BMI 55. And this is their oh, wait a minute. BMI or age. Yeah, okay, this is their BMI. Okay, so BMI 55, they had weight loss surgery, they got down to BMI 37. Big drop. Still obese, big drop. And you look at their AHI, so they start out with AHI almost matching 55 on average. On average, it came down to 15. So you had some patients where their sleep apnea is resolved, but on average, they were still left with kind of moderate. Now they still had high BMI, 37, but they were left with moderate disease. So this still puts them at risk for long-term consequences. You know, we have a lot of patients starting BMIs in the 40s, some even in the upper 30s, getting weight loss surgery. And a lot, they'll lose weight. You'll see if you're watching up these patients, they lose weight for about a year and a half, and it plateaus, hopefully plateaus, some start going back up. They feel better, right? They can breathe better, they can more energy, they exercise, they're peeling off their blood pressure and diabetes medicines, and then throw away that CPAP, and they feel so much better, sleeping better. But what they're supposed to do is come back every study, because you're going to have some of these patients that are still going to have significant sleep apnea and still need treatment. It may not be CPAP they need anymore, maybe they need something else. Maybe get by with an oral appliance, or maybe some adjunctive surgery to take care of. You know, even with substantial weight loss. Now, again, granted, this is starting from very morbidly obese. They still had some sleep apnea. So this is that you guys heard about this. This is the Surmount trial just came out a couple weeks ago. This is all the talk, you know, at the sleep meeting. So all these GLP-1 drugs that are being used, so Ozempic and Zepbound or what's it called, Wegovy, tirzepatide. So tirzepatide seems to be much better compared to Ozempic, and it is this was against placebo, and they did 2 studies in one. So they had patients that they all have OSA, and they were overweight, and they got this drug. And trial one was people not on treatment, and trial 2 was people on PAP therapy. And what you saw, this is looking at their BMI, so they lost substantial weight. This is, oh no, I'm sorry, this is their HI, which one's their BMI is the bottom. So they lost substantial weight, they lost 20 kilos. It's going out to a year in both groups. And their HIs went down quite a bit. So it goes down by 30 in each group at a year. So that's pretty dramatic. But there's some caveats. So there's a lot of talk, you know, this can be a new treatment option for sleep apnea, and people won't need CPAP anymore. But the question here, do you start this? Do you start with CPAP? Yeah, whatever. But there's some caveats to this as well. So one, right, just like, oh, they got to stay on this drug lifelong. So they come off it and rebound. So it's a kind of controller like CPAP, like oral appliances. But 2 is that, so they report the change from baseline. Their baseline HI in this study, again, was 51. So you're still left with an HI of 20. So this is not standalone therapy for a lot of these patients. It's improved their sleep apnea. Maybe they could buy again, maybe it's made it so they can take an oral appliance and not need PAP therapy. But be careful, this got a lot of press in the a lot of news in the lay press and the medical community cited, and people are going to come to clinics now asking just for this type of treatment. And my guess is we'll probably be prescribing this before too long. It's not FDA approved. They did put in, Lilly put in for FDA approval for this as a sleep apnea treatment specifically. And again, it's not going to work for patients who aren't overweight. But just keep those things in mind. So it is going to be something that's going to be new that will probably be part of our treatment options, but it's not going to be, you know, a home run. It's not a panacea. So we'll talk about the mainstay treatment options, and we'll talk about the alternatives, and then we'll wrap things up. So PAP therapy, you guys know what this looks like. The device here at the bedside, the hose, patients who are in CPAP. The basic machine, you'll get into more detail over the year. So this is the pressure generating part, and then there's a humidifier chamber, tubing, which can be just plain non-heated, and then we recommend heated tubing a lot of days, for a lot of our patients nowadays, just because it makes it easier with humidification, which reduces one of the main problems of PAP therapy, which is dryness and congestion. And then the mask. So the reason we go to CPAP is first line for most patients is it works for almost everybody. There's some patients where it doesn't. We'll talk about treatment emergent at some point, sleep apnea. Really, some patients, really hugely obese patients who are even with the really high pressure, they have trouble with that. But well over 95% of patients, this works very well. Pressurizes the upper airways, maintains airway patency. When those muscles start to relax and the airway wants to collapse, it prevents that from happening. Usually it's titrated during a PSG, although we're using auto devices almost exclusively now. There are some patients we still bring into the lab, but self-adjusting device, it becomes sort of the mainstay. Most insurance will approve it. We've had some problems. Care source for a while. So strict Ohio Medicaid says patients have, it's totally stupid. So patients have to come to the sleep lab to have a PAP titration to prove that it works. And care source during the pandemic, they said, okay, let's set up auto PAPs, but now they went back to saying, which is care source is a major Medicaid supplier in Ohio. No, they got to come to the lab. We had to argue with them. We actually had to call them and say, look, you idiots, it's costing you guys money. You're gonna pay us for another study to do this. It's delaying care. And they actually came around and finally said, okay, you have to. But there are United Healthcare Medicaid still required. So it's so stupid. Medicaid is supposed to be trying to do everything it can to save money. And we're making money off of them, but it's like food, it's stupid. But anyway. So auto devices becomes standard. There's full face mask, there's nasal mask, there's nasal pillows. Those are our standby ones we go to. Rarely use this, almost never in the outpatient setting. Use inpatient as a really full face mask because of the forehead and under the chin. There are a lot of hybrid now devices, oral and nasal pillow type things. And there are oral devices that came out, a lot of fanfare about 20 years ago. They haven't been that successful because they're just so drying on the mouth. But you'll see the various labs will use different approaches. Dr. Patel is really opposed to full face masks. We've tried it with our techs. They keep going back to the full face mask, keep telling them to stop. There is some data that these actually with the full face mask, when they're a little too tight, they'll push the mandible back. So you actually end up compressing the airway, even higher pressures to keep it open. But a lot of our patients actually prefer them, and our techs really like them. A lot of patients will drop their mouth open, so that becomes a problem. You can use chin straps with both these things to overcome that. These are better for people who have less claustrophobia, tend to side sleep better. There are CPAP pillows you can buy. So there's a whole bunch of different interfaces, and you'll spend a lot of time in clinic, talking to patients about their interface and trying to sort this out in concert with the DME companies. We know that it reduces sleep disorder breathing and their daytime symptoms improve rapidly, often within a day or two. Improves oxygenation, exercise function. Patients that have high hematocrits, it can improve that. Neuropsych measures get better. Decreases motor vehicle accidents. There's a lot of data on that. Hospitalizations. We think it may decrease mortality, but that's been hard to prove, obviously, in randomized controlled trials. Problems are acceptance is suboptimal and compliance is poor. So this is a classic sort of observational study that looked over a 10-year time period. And the group that separates are looking at fatal cardiovascular events, non-fatal cardiovascular events, pretty large study. And they had controls which didn't have sleep apnea. People just snored, no sleep apnea, mild, severe, and then the OSA on PAP therapy. The group that separates out in terms of having more fatal and non-fatal cardiovascular events over the roughly the sort of the 5-year time period or sooner, were those that had severe OSA not on treatment. Your sleep apnea and you're on treatment, you look just like everybody else. So based on all this data, I thought, oh, we're doing wonderful things with this, and people are like, well, wait a minute, there's big bias in here, right? The healthy user effect, all that. So then there have been a bunch of randomized controlled trials. And that's where things have kind of come into problem. So this is looking at according to non-randomized controlled trials. Yeah, great benefit. Look at that. We're dramatically reducing mortality. All these studies. This is a meta-analysis. Actually, this is Sushil, Dr. Patel. When they looked at randomized controlled trials, a bunch of these studies came out like 5 or 10 years ago. There's no benefit. There's some problems with these randomized controlled trials, though, and their compliance was relatively poor in a lot of these studies. Some were starting with groups with some risk some not, length of study follow-up. So it's really been, it's kind of hard to say that we are definitely improving mortality, and then same sort of thing with the cardiovascular events, non-randomized trials, yay, randomized trials, boo, didn't show true benefit. So there's been some other attempts to look at this, is that when you look at compliance, so if you just go through and take those studies and you look at the group that's the subset of patients there, so they all did intention to treat. But obviously, you got some people that just didn't use it at all, some that used it suboptimally, and then some that used it. So if you went back and said, okay, so we consider compliance with PAP therapy is 4 hours a night, and actually there's this, I consider 4 hours a night. The standard is 4 hours a night, 70% of nights. That's what Medicare considers compliance. 4 hours a night, 70% of nights. And that's what all your patients need to do in the first 3 months, otherwise they stop paying for it. But if they went back and looked at patients who just use it more than 4 hours a night, so some of these big studies, so there's a SAVE or COTS study and the Circus study, see the hazard ratio dramatically drops in terms of cardiovascular. So it's beneficial. So it's like one of those things, right? You use it, it's going to help you. You don't use it, it's not going to. But the message, unfortunately, has gone out of these things is that people out there, CPAP's not changing cardiovascular. In terms of sleepiness, it does. So the one thing that was a benefit in all the randomized controlled trials with intention to treat was it did improve symptoms. So sleepiness does go down. So then Dr. Javahari, he's in Ohio, he's down in Cincinnati. This is a guy who does sleep and has an interest in cardiovascular stuff. He's done a ton of studies, a lot of landmark studies. You'll see his name pop up a lot. When he went and sorted these things out and looked at these studies again by compliance, so this is a different analysis, and looking at just compliance for primary and secondary outcome, he actually did see a benefit to taking those randomized controlled data from those studies in patients that were compliant. There was benefit in primary and secondary outcomes that was largely driven by actually reduction in stroke, so teasing it out a bit more. So not other cardiac outcomes, which, acute MIs, revascularization, heart failure, cardiovascular death trends towards improvement in mortality, but not quite significant. But it really seemed to reduce the stroke risk. So the one thing we say for confidence with our patients is that, if you use this, it's going to reduce your risk of stroke for sure, and it should improve your symptoms. Yeah. And there's actually this data didn't look at it, but hypertension, there's no data supporting hypertension. I'll show you some of that. So there it is. And this is probably translates into why some of the stroke risk is reduced. So this is looking at mean reduction in the blood pressure for patients with simple hypertension. So it's 2 and 3 for these are a variety of different studies, but kind of averaged out around 2 to 3 millimeters mercury systolic diastolic or 24-hour time period. Say, 2 to 3, big deal. That's not that big of a drop. But actually, when you look at mean blood pressures and stroke risk, it's you need only about 2 millimeters mercury drop in order to improve the outcomes. And this is looking at patients resistant hypertension. You're saying, Kate says that meta-analysis again from all these studies showing that if you have a resistant hypertension, it's a much bigger drop. So here it's along the lines of 8 to 5 to 10 or so in terms of millimeters mercury for systolic and diastolic pressures. So pretty substantial. So for some patients, it will improve their blood pressure. It will probably reduce the risk of stroke and should improve symptoms. Those patients, like I said, there's some that still remain sleepy. We talked about earlier. It does improve pulmonary hypertension. The study looking at sham CPAP versus CPAP and the drop in the systolic pulmonary pressure by echo lower, and there's a number of studies looking at this as well. Excuse me. And then this is a study I like to refer back to patients as well, or relate to them. This is a study looking at the hours of use and then a number of measures of quality of life. So one is sleepiness, which is as measured objectively by the MSLT, as measured by the Epworth here, then is measured by their functional outcomes of sleep questionnaire, so quality of life. So once you get above that 4-hour threshold, so it rises up. it continues to go up for every additional hour use. It just starts to plateau when you start getting closer to 7 hours of use. So I tell patients this, 4 hours is the minimum, but the more you use it, the more benefits you're gonna get. So you should strive to use it the whole time you're sleeping. William Shatner. So William Shatner is now in his 90s, but he's been diagnosed with sleep apnea and been, verbal about it. He's not overweight at it. So there's problems with CPAP. So just briefly, a lot of these things we can overcome. Nasal congestion and dryness actually is a big thing. I ask all my patients about dryness. So you got to make sure that you're using a heat humidifier. They have heated tubing. You have to order this a lot repeatedly. Sometimes nasal sprays will work. Sometimes biotin works. Addressing leaks will work. They have bad air leaks and maybe interface related, so that's a big deal. One of the big things we set people up on PAP therapy, they get 30 days to swap out whatever they choose for free. After that, they got to pay. Maybe pressure related to some chest pressures. Some patients claustrophobic, so interface again. Desensitization exercises can be beneficial. This is where you have patients practice during the daytime. So you'll hear more about this over the year. But this is where we have handouts for it, but you tell them, put it on while you're reading, watch TV, early afternoon or middle afternoon. And just wear it for like 30 minutes, an hour, and then take it off. So put it on, just do that for a week, 2 weeks, lengthen it out, and then start using it. So it becomes less of an issue. Their brain gets used to having it on, their face gets used to having it on, they used to breathing with it. It's not such a big deal when they go to put it on when they go to sleep. Because a lot of patients get anxious, gets them all worked up and they can't sleep. Pressure intolerance, so changing to auto PAP. There's some other things we can use. Aerophagia can be a big problem, so they're actually swallowing air. A particular problem with higher pressures, full face mask, and if they have reflux, and just refusal, so alternative therapy. So adherence is a problem. Patients often report adherence when you measure it objectively, which we do, and you guys will see how to do that. It's often less. However, people tend to really poo-poo this, that's terrible, blah, 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 when you compare it to other things. Adherence asthma medications, 30%, so it's better than that. So the general rule is sort of about half patients will use it adequately. Probably about another quarter struggle with it, and then another quarter is refused. I have a lot of patients, you hear about talk about a lot of patients that can't sleep without it. It's the best thing ever. They love it. Their compliance data looks great. I'll show you some compliance data. Things that predict poor compliance, so bad understanding of why they need it. Other drugs or alcohol that can interfere if they don't perceive they're benefiting, so they're not sleepy. I have one patient, he doesn't feel like it helps, but he knows it's probably helping him medically, so he sticks with it. But he doesn't notice any difference in how he feels. He doesn't really feel that tired or sleepy, but his HI is high enough. He knows that he's got cardiovascular risk. Nasal obstruction can be a problem, side effects, claustrophobic PTSD. A lot of things with education, frequent follow-up. This is us and the DMEs doing this. Desensitization therapy talked about, motivational interviewing, equipment optimization. So we spend a lot of time in clinic doing these sort of things. Like I said, we use AutoPAP these days. So, AutoPAP is basically self-adjusting CPAP. So we set a range, and what it's going to do is the machine has to look at their breathing. And if it sees that the airway is starting to collapse, it'll start to go up, and the pressure goes up by 2, and then it holds it there. And if it will monitor for a while, if it sees the airways collapsing, it goes up again. And then eventually, if it sees normal breathing, it stays steady. And then if it's normal breathing for a long enough time period, it'll lower the pressure. The pressure will float with the person. So that's important because sometimes things are much worse on their side or on their back, or when they go into dream sleep, so the pressure may need to be different. As opposed to when we do a titration in the lab, we pick a pressure that controls it when they're on their back in REM sleep. If they're worse, they may have higher pressure. So a lot of people tolerate better. Out of the box, compliance is no better one versus the other, but because it doesn't require new study, PAP costs have come down. We use these a lot for most patients now. In case patients that are failing, AutoPAP will go into BiPAP. So BiPAP is where they breathe in, they get a pressure, breathe out, it drops in, out. So this is particularly useful if they have hypoventilation, or if they have some pressure intolerance, or they need very high pressures above. So CPAP will max out at 20 with bi-level devices. We used to go to 30. Most manufacturers will max out at 25 now. you can get by with much higher pressures if patients tolerate. It's just much more expensive. This has to be titrated in the lab. There are auto adjusting bi-level devices, but I'm not sure I trust them totally. So those are more expensive than fixed pressure ones. So just one thing to be aware of. There's a couple of bench studies that looked at this. These are so what they did was they mimicked sleep apnea events. So that's these black bars, apneas. And then these are hypopneas. And what they did, so this is just apnea, hypopnea. They took a bunch of different auto-adjusting devices and they said, okay, hooked them up to these things and said, let's see how you perform, see what you do. And so this device here, it ramped up to a certain pressure despite ongoing apneas and it stopped. So all the auto devices have different algorithms and some are set to lock out at a certain pressure because they can't tell if it's an obstructive or a central apnea if they're not measuring effort. And they worry that they're going to induce central apneas if the pressure gets too high. So this device for apnea is totally ineffective. And for hypopneas, it went up a little bit, eliminated partially the hypopneas, but then stopped. This one kind of kept going up, partially eliminated, but so these aren't very good devices. This one, however, did what it was supposed to do. It went up, eliminates the apneas, and it held the pressure. Eliminate the hypopneas, kept going up. So it gets sort of a silver star for that. And then we got a couple of gold stars where this one went up, eliminates the apneas. Okay, apneas are gone. Go down, titrate up, reappearing, up again, down to, so the pressure's floating. Same thing with hypopneas. So these are kind of the optimal devices. The problem is knowing which ones these are can be a little bit tricky. So these ones, a lot of these ones they did, this was an overseas study, are not available in the US. And, the study's old and there's much different devices. So you got to be a little careful with the auto devices, as just being cognizant of which ones. So the pressure limits we set are often empiric. So I base this on severity of sleep apnea and BMI usually. So the heavier a person is, the lower the bottom pressure I'm going to set. And, so I may go 10 to 20 in someone that's got a BMI of 40 or their sleep apnea is really bad. The thinner, the lower it is, I may go lower. So I've even started some patients as 4 to 12. My standby kind of average person is usually 6 to 16. Then the downloads are important to monitor. So interface may be adjusted, pressure limits may be adjusted, and close clinical follow-up. So you're required to see patients once they start on PAP therapy within 90 days. Ideally, it should be within 2 to 3 months. This to reassess, see how they're doing with their downloads, and see if you need to make some adjustments. But DME companies should follow up sooner than that. For bi-levels, fixed pressure. So these are usually titrated in the lab. I'll talk just a little bit about downloads and we'll talk a little bit about alternatives and then we're going to wrap this up. Or do you guys need to take a break? No, you're good? Okay. Sorry, it's a long talk. So compliance mandated by CMS 30, 60, 90 days. Most insurers will follow this. So 90 days. The problem is that some patients have issues the first 90 days. It takes that long to get them squared away. If they lose the device, so what happens is the insurance say, I'm not going to pay for it. The DME says, I'm not getting paid for it. You got to bring us back. And then to get them back on therapy, usually it's totally stupid. You have to bring them back in for a titration study. And you can reorder it and then they'll approve it. So it's totally stupid. Instead of letting us continue to work with patients, because most patients will try and get back on therapy. There are some that will go on to alternative therapies. So the downloads report the CPAP setting, the percentage use nights, percent 4 hours a night or more than the average hours. And then and then they all report. So that older things, all of them now report machine detected AHI, which if the AHI is low, it's actually pretty accurate. If the AHI is kind of middling or high, it's a little bit of a guess. So then I usually get some confirmatory testing, depending on if the patient's having symptoms or not. And then the leak. So this is what one of them will look like. So this is an air view. So ResMed does air view. You guys will get logins for this, so I'll give you that. Philips Respironics, which is in big trouble, not making any devices, selling any more devices. They have Care Orchestrator, which I don't like very much. It's not as user-friendly website. But each column represents a night. So here you're seeing so green is good. That means they use it over 4 hour threshold. So this red is a night they used it, but didn't use it for 4 hours. This is showing their leak and what the acceptable leak is. So all devices have an intentional leak because you can't breathe, otherwise you'd be rebreathing CO2, so you gotta leak some. So there's a leak set that's acceptable, it's around 20 usually. So it's not, so if you had a high residual HI and they're leaking a lot, then it's probably their sleep apnea is not well controlled because they're leaking so much air out, it's not splinting the airway open. So this is looking at the pressure. So this is a fixed pressure device set at 12. I don't know why I dropped to 10 for 2 nights, but 12. And then you see the machine detected HI. So most of the time, this person's doing pretty well. And you'll actually get an average over 30. You can set these for 90 days back at it. So good, great compliance, good control, no air leak. This is a gold star patient. Here's someone, some nights are missing, high leak. And then you'll see, sometimes you'll see this correlate, not always. So their HI, despite that high leak, their HI is still low. But you've got to fix the leak. So it's up over 80 on many nights. So they may be complaining about it. They may be symptomatic, or the HI may be high. This one's actually okay. This one, I will do this occasionally. A lot of practitioners don't do this, but oximetries in some cases where I want to verify that things are under good control. Say the person's still sleepy and the machine reads out looks like a low HI. You see on this person's oximetry, they actually had some problems here. They're dropping into the 70s at times. It's the whole night crunched together. So if you look at this in the short term, they're really doing this sort of thing. And it's probably when they're entering REM sleep. So the pressure is probably not adequate, or they're leaking too much. Probably pressure is not adequate to control their sleep apnea. And so this person probably needs to have a pressure reassessment or come into the lab to get rechecked. But I'll use oximetry sort of as a secondary confirmatory test in some patients. So they're really hypoxic at baseline, ongoing symptoms despite a download looks good. So we'll see this occasionally. Didn't use it at all. Use it a couple nights, only one night adequately. Again, has a high leak on all those nights. HI is really high on this first night. Maybe been in and out of sleep or something. So this person's doing bad. And follow up with them. Who's this guy? Yep. Sleep apnea. He was actually been very public about it. He did a PSA with all the Harvard sleep docs talking about his CPAP. All right, so alternative therapies. So the big other two buckets that we talk about are oral appliances and surgery, and we're just going to kind of skim over some of these and other alternatives and wrap up here. So oral appliances have been shown to work as well as CPAP. Again, controllers for mild to moderate sleep apnea. More severe sleep apnea are not going to work well. Data suggests that they work as well, and they're a little better tolerated. My clinical experience has been they don't work as well. So the problem with these, why I usually put them more second line for most patients, is unlike CPAP, which patients rent to own, right? So they don't buy a CPAP. They rent it, their insurance covers most of the costs, there's a copay, small copay, a year, they end up owning it. Oral appliance, you gotta buy it, because they're custom made, upper lower plates, they're adjustable. The dentist adjusts them optimally, and then you restudy them. And the problem is, my clinical experience worked about half the time. And so you have someone, the insurance usually will cover these, but they're very expensive, a lot more expensive than CPAP. CPAPs are generally $600-800. These are often dentists, particularly in private practice, $2,000 to $4,000. And so you got to buy it. And so now if they don't work, and you bring it back in the lab, oh yeah, I feel better. I don't think I'm snoring as much. It's optimally adjusted. Okay, let's study you. And it's not working at all. And now you spend all this money for nothing. So that's the biggest problem I have with them. You can use them in some patients. They have that, so I always check for TMJ, open, jet their jaw. If you get all cracking and popping, it's probably not a good idea. It's going to put strain on the TMJ, put some strain on the muscles. They often get some soreness. They'll give them exercise to do. Some patients drool, some get dryness. Those things tend to get better. They got to have enough teeth, which can be a problem in our patient population. You have 6 upper and 6 lower. There is one that's made for dentless folks. It's a tongue retaining device. It pulls suction bulb, pulls the tongue forward. It's not super effective. They can't have bruxism. So if you have bruxism, they can chew right through these things, and they gotta have. So you can't get a new one every 2 years. So repeat study. can be a home test is mandated once they're optimally advanced. So surgery, again, tons of surgeries that can be done. You know, the biggest newest one is a hypoglossal nerve stimulator, but they can fix the nose, they can take out tonsils. Our OMS colleagues, they'll fix the jaw, they can advance a little faceplate. That can be very effective in the right patient. These are best done in patients that are not as obese. They're generally healthier, they have more mild to moderate sleep apnea. And again, once fully recovered, you usually got to wait several weeks till its swelling go down, and you want to repeat a study to see where things are. There are some select cases we'll do as adjunctive therapy. We realize it's not going to cure a patient. We publish a case series of this, patients who had bad sleep apnea and they're way overweight and they weren't very good with their CPAP. And we said, but you know what, you got big tonsils or you got a nose issue, that's probably not very compliant. So let's fix that. So we send them get their tonsils out, knowing it's not going to cure their sleep apnea. Their HIs come down, but they're still up to pretty serious sleep apnea. But now they're able to use their CPAP and at lower pressures because now their airways been more fulfillment. So there are some patients we do that as an adjunct. So oral appliances, so basically what they do is they'll anchor the tongue and they just pull all this forward to open up the back of the airway. There are some people that are fans of them, that we have some people that specialize in these. Some of my colleagues tend to refer more for these. My clinical experience hasn't been great, so I'll still send patients for them, but always caveat. Predictors effect, so they're called mandibular retaining devices, lower HI or MADs, mandibular advancement devices. Not as bad, lower age, lower BMI, supine dependent. So if they're more prone to supine, I mean gravity is playing a bigger role, that may actually work better with these folks. There's certain cephalometric things, so they don't do that as much anymore. Our OMS doctors will do these Cohen CTs, get a better sense of the airway. And not a lot of nasal issues.
Do you ever recommend people that may potentially be at risk for a lot of nasal polyps or other reasons to kind of increase obstruction? Do you ever recommend them going to ENT?
Oh, yeah, we work with them. But you always have to set expectations about why we're doing the surgery.
Yeah.
Is it going to cure? So like this is the ASM slide. I threw this in as adjunctive, which they probably came out apart from our thing. Our study is to facilitate or salvage. So it's someone that doesn't want PAP, can't tolerate it, fails CPAP or any advanced device. There's a whole bunch of things, but there is a guideline out. It's pretty old now, but generally like things like they only looked at a few of these surgeries and most were not recommended strongly. Trach is still an option. Mandibular advancement works well in the right patients, and then hypoglossal nerve stimulator. So if no appliance is made, the dentist is responsible for fitting, advancing, monitoring, advancing it, and then we follow up the sleep study, and then if they're doing okay, we just follow up periodically. If surgery is performed, ENT to decide on the type of surgery, or the oral surgeon, and then follow up after the surgery, and then we follow them with the sleep study after that. So the hypoglossal nerve stimulator, you guys probably heard about this now. Inspire is the big company that does this. There's another one that's coming out too. Basically unilateral, usually on the left side, or I'm sorry, on the right side, stimulates the hypoglossal nerve, and basically what it does just protrudes the tongue. So it's an inserted device. They have one lead that goes down to sense when they're breathing. As soon as it senses they're breathing, it activates hypoglossal nerve and push the tongue forward. So the tongue kind of push forward back. So the patient, once it's healed, patient gets a remote to activate it. They have to come into the sleep lab to have the settings adjusted. So it's actually kind of complicated. You guys will hopefully all get trained over the year. I'm not trained in doing it, but Dr. Carter is, and some of our nurse practitioners got trained. So they see these patients once they're implanted. There's a lot of fiddling around with it. And the hope is that it works. And the data suggests that it does work for most patients. There are criteria for it. So they got to have at least moderate sleep apnea, but not extremely severe. You can't have central sleep apnea. This is a bit of a moving target. It was initially 35 or 32, I think, and 35. Then it got to 40. And now a bunch of insurances are doing somewhere between 35 and 40. So it depends on their insurance. The problem is the heavier they get, that it takes too much amplitude to push the tongue forward. It tends to work not as well. We had a really aggressive surgeon previously who was doing a lot of these patients and just wasn't working on it. They have to at least try CPAP, fail it, or don't want to use it. And then they have to undergo a drug-induced sleep endoscopy. So this is something that we could do, but we've kind of handed over to them and our OMS docs. they bring them in, anesthesia gives them propofol, knocks them out. Put a small scope down. What they're looking for here is anterior posterior collapse, which happens in over half of patients. If it's concentric collapse, the device doesn't work through. So anterior posterior pushes the tongue forward, it looks really well. It's concentric and more lateral wall stuff, pushing the tongue forward doesn't help all that much. There are sometimes some surgeries they will do then to try and convert people from concentric to AP. So we got the ENT docs to decide that. The data, and there's now data coming at least 5, maybe 10 years out now. So this is baseline at 12 months. And this is both on therapy, and then another group, they stop the therapy and see their sleep apnea comes right back. Suppose you continue it, but this is going from 30 down to 7 on average. So a lot of these patients achieve under 5. Our goal is to get them under 5. CPAP routinely does that. We'll take 5 to 10 if they're asymptomatic. That could be okay. But it looks like it. So in the patients make criteria, insurance will pay for it, and you get them adjusted, and it works. It works pretty well, and it will continue to work for these patients. It's just ODI versus AHI. There are some positioners. Generally, they'll use these as first-line therapy. These work for people that really have predominantly supine. So the AHI maybe 3 when they're non-supine, they turn supine instead of 40 or whatever. So you can keep them off their back. There's a variety of things. There's inflatable vests they can wear. There's wedges. There's kind of backpacky type things. Insurance typically doesn't cover these, but they're not that expensive. The biggest problem is really compliance. Again, when they've tried to look at this, actually patients aren't any more compliant with these than they are with CPAP. But if you keep them off there, and there's also things that there's buzzers that if they'll sense it on their back, it'll buzz and wake them up and get them off their bed. The classic, the old traditional thing was sew a pocket in your pajama top and drop a tennis ball in there, and then that keep you off your back. That doesn't work. Someone actually studied it. So less severe, younger, less obese tends to work better. I usually use it as an adjunct or backup. Provence, there's some things that have kind of come and gone, so you always have to be a little cautious. You don't want to be first on the bandwagon. These look great. There were studies suggesting these things. They were kind of one-way valves. They'll just bandages, put on your nose. You breathe in through them. When you breathe out, the valves collapse, create some back pressure, so it creates some cap in the back of the airway. And in studies, Baldemar CPAP looked great. And then everybody started using them, and insurance wasn't covering them, so patients had to buy these things. And it turns out in practice, they just didn't work that well. A lot of people didn't tolerate them. And then they just weren't that effective. So the company actually went bankrupt, and they came back to try and market them primarily for snoring. There's a newer version of this called the Bongos, which Dr. Carter's used some. I haven't used. I'm not gonna have high hopes for it. But maybe for mild sleep apnea, it could be considered. There's instead of forcing air in, sucking air out. So there's this thing called the Winks, which came out, and it's got a lot of fanfare and press. So it's a mouthpiece, but creates negative pressure, so it's suction to pull the tongue forward. Looked great in a couple of studies. Everybody thought it was going to work really well. Turns out that a lot of dryness, intolerance, couldn't get a good seal. Just nobody uses these. So this is one of the things we were trying to study here. UH was also this big study. They lost their funding or something happened. This CNEP, continuous negative expiratory pressure, so like seals at the neck. What it does is create some negative pressure there to pull the soft tissue of the neck forward. So by doing that, it opens a space in the back of the airway internally. Can't use it if you have carotid disease, because of too much pressure on that, it causes problems. Initial data looks promising. They're trying to study in a larger multi-center study, but it's not the study to hear about. This excite thing, which is something to try and increase the tone of the genioglossus and the tensor palatini. It's a daytime oral thing. So there's been some data on actually originally came out of using the didgeridoo, that Australian instrument, that if you can strengthen the upper airway dilator muscles for some patients, that can help their sleep apnea. So that's translated into some speech therapy exercises and into this device. So it may work. There's some data suggesting these things may work in some patients with mild to moderate sleep apnea. You gotta have a really good protocol. This device wouldn't be covered by insurance. And if you ever were to use, I haven't utilized it, but if you ever were to use it, make sure you can study it. Actually, medical therapy, so if they were hypothyroid, you want to treat that, that can actually improve things. Nasal steroids for chronic rhinitis, we talked about. This is the latest one that's on the, not on the market yet, but it's under FDA review. Looks promising for some patients. It's a combination of stimulant and an anti-muscarinic to improve the P crits and reduce loop gain. So I'll show you some more on that. And then stimulants we do use for those patients with residual daytime sleepiness. These are primarily ones used. Not clear if you need to get MSLT on these folks or not. Routinely don't. This is the data on atomoxetine and oxybutynin, which that's going to be called, I think, apnea med. So placebo, this is looking at AHI, placebo, and then with the combinations, you can see the AHI drop from like 15 down to 7. Say ODI. HP stands for. So again, it's not going to work. You know, if you got severe sleep apnea, it's not going to be an adjunct therapy. It's not going to be a cure-all. But you have mild, moderate sleep apnea, maybe a pill you can take through your sleep apnea. This was last year. I still haven't seen it. It's approved, so they applied for a fast track. Okay, when is another study needed? If someone's on PAP therapy, if the original titration is suboptimal and there's ongoing symptoms, persistent symptoms despite good compliance, lack of other treatment issues, you can pinpoint. If they need to change the PAP therapy, going to bi-level or more advanced therapy. And then if they had, you know, it's recommended if they had significant, so it's usually considered 10%. It's not, we don't always do this. The patients, you know, if they're still compliant and data looks good, they're sort of needed. But a lot of, we're using AutoPAP so much anymore, it's kind of an issue. But and you usually don't repeat sleep studies on the bariatric patient. I mentioned they're dropping the rate like this. You don't want to repeat them when they're here. You know, you want to wait till they plateau, so you don't repeat a study till they're here. Recovery from surgery and oral appliances we talked about. Who's this? I think the last few slides. What's this?
Oh, CPAP shot.
Yeah. So yeah. Made national news. This was identified by a reporter, right? Yeah, sleep apnea.
Is it helping his neurocognitive
Well,
status?
that's up for debate. Okay, and then the final, who's this? How'd you know that?
This is Dr. Chang.
Huh?
I think Dr. Chang talked.
He's like, you would like
Still
fall asleep everywhere.
Yeah, okay. Okay, yeah, there's an article in Chest about 25 years ago where someone went back, a physician went back and just did some medical history and looked at this. And it's really interesting. You probably showed you these graphs in already. Let me show you this.
Oh, wow.
So this is looking at him. So it's interesting. So he was, you know, lawyer, got into government, ambassador to the Philippines, and this is looking at his weight and his BMI. So he gained a lot of weight. So his wife actually said when he was ambassador to the Philippines, a hurricane came through and knocked down their house. They survived. He barely slept through the hurricane. His wife was up freaking out. So he came back, lost a bunch of weight, became Secretary of War, popular, got elected president, gained a bunch of weight again, one-term president, did not get reelected, lost a bunch of weight, and then got elected to the Supreme Court. And on the Supreme Court, he was apparently, you know, super prolific, wrote all these opinions, you know, was considered to be a great justice. But he had lost a bunch of weight then. So the person was surmising that when his BMI got up here, he probably had bad sleep apnea. So sleeping through hurricanes, and also apparently when he was president, said, I don't even remember I was ever president. It's supposedly him sleeping during a ship inspection while standing up, that he couldn't stay awake at all. His advisors apparently ran the meetings and stuff. So he had severe neurocognitive and sleep impairment resulting from presumed sleep apnea, but you know, nobody knew what sleep apnea was. So anyway. All right, so sleep apnea is very common. Clinical evaluation, objective testing, this combination, probably screen people at high risk, and then treatment. All right, so that's your sleep apnea overview.